Chair of the Health and Human Services Committee. I would like to invite the members of the committee to introduce themselves, starting on my right with Senator Day.
Good morning. I'm Senator Jen Day. I represent Legislative District 49 in Sarpy County.
Thanks for being here. I'm Merv Riepe. I represent District 12, which is Millard, Omaha, and the little town of Ralston.
Also assisting the committee is our research analyst, Bryson Bartels, and our committee clerk, Christina Campbell. A few notes about the policy and procedures today. Please turn off or silence your cell phones. And we will be hearing one legislative resolution, and we'll be taking the order listed on the agenda outside the room. On each of the tables near the doors to the hearing room, you'll find green testifier sheets. If you're planning to testify today, please fill one out and hand it to Christina when you come up to testify. This will help us keep an accurate record of the hearing. If you are not testifying at the microphone but want to go on record as having a position on a bill being heard today, there are yellow sign-in sheets at each entrance where you may leave your name and other pertinent information. Also, I would note, if you are not testifying but have an online position comment to submit, the legislature's policy is that all comments for the record must be received by the committee by 8 a.m. the day of the hearing. Any handouts submitted by testifiers will also be included as part of the record as exhibits. We would ask if you do have any handouts that you please bring 10 copies and give them to the page. We use a light system for testifying. And I think today we will maybe try to, how many people, if you can raise your hand, how many people are testifying today? I think I have a pretty good idea. Okay. So what we will probably do is limit it to 3 minutes for each testifier. So that way we have time for questions. I just want to make sure we have adequate time to make sure people on committee can ask questions so we're not going until 1 o'clock. When you begin, the light will be green. When the light turns yellow, that means you have 1 minute left. When the light turns red, it is time to end your testimony, and we'll ask you to wrap up your final thoughts. When you come up to testify, please begin by stating your name clearly into the microphone, and then please spell both your first and last name. The hearing on each bill will begin with the introducer's opening statement. After the opening statement, we will hear from supporters of the bill, then those in opposition, followed by those speaking in a neutral capacity. The introducer of the bill will then be given the opportunity to make closing statements if they wish to do so. On a side note, the reading of testimony that is not your own is not allowed unless previously approved, and we do have a strict no-prop policy in this committee. So, yes. And just for the record, we do have invited testimony today for this hearing, and so we will be taking the order that we have listed on our sheet here. At the end, we will, just to make sure, see if there's anybody in opposition after testimony, see if there's anybody here that might have some conflicting views. So with that, I will go up to the front and start with the opening statement, and then we will start with our testifier list afterwards.
It was all mine.
Okay. Good morning again.
Good morning.
Members of the Health and Human Services Committee, my name is Ben Hansen. That's B-E-N-H-A-N-S-E-N. I'm opening on LR 392, an interim study that examines the costs and frequency of rebasing provider rates and to develop a methodology for rebasing these rates. For years, providers in Nebraska's healthcare industries have developed various methodologies in calculating their rates. Some providers have rates established for them in an arbitrary manner without even submitting cost reports. In my years of being a senator, I have observed that health providers' rate methodologies are inconsistent, fragmented, overly complex, and arbitrary. My purpose in introducing this study is to develop a rate methodology that can be used for all providers. LR 392 examines the factors used in determining current provider rates, factors causing the frequency of rebasing, cost reports from providers, projected state and revenue, inflation rates, amount of Medicaid reimbursement, type of providers' rates, and comparison with each type, comparison to Nebraska provider rates with other states, and new technologies, services, and provider types that require a payment methodology or rate. My staff worked with NCSL during the interim to see if other states have used a universal or statewide rate methodology. We found that Maryland uses a total cost of care model, which is an all-payer hospital global budget model designed and funded in collaboration with CMS. Oregon uses a coordinated care model based on performance, paying for outcomes and health maintaining costs at a substantial rate of growth. There's more detailed information in my handouts. Also, during the interim, my staff met with the Nebraska Healthcare Association, Nebraska Association of Behavioral Health Organizations, DHHS, CAFCON, and Child Welfare Providers. First 5, home health providers, Leading Age, NASP, APACE, DD providers, Mosaic, and Legislative Fiscal Office. We found out that many of these use different methodologies or provided a rate with no methodology at all. However, we also found common denominators regarding base payments such as costs and revenue streams, adjustments such as inflation, supplemental payments such as provider assessments, and incentive payments for performance, reporting, or quality. Finally, I believe that providers should have more certainty in developing their budgets. A statewide methodology would provide a more clear direction for healthcare providers so they can deliver the more important services to vulnerable populations. Today, I look forward to hearing from the following testifiers, and I would be happy to answer any questions. And on a side note, so I think the whole purpose of this study, as many of you know, every year we have many providers come to us wanting a 20% increase in their budget or their reimbursement, or 2% or 5%, and then it's up to us to figure out who's more important than the other ones. You know, what can we afford? And then go to Senator Clements and he yells at us. So what we're hoping to do here is is there a way possibly, like some states have done, to find a universal kind of formula that we can use? So then we have some idea of maybe what our budget's going to be like in a year or two with provider rates. Providers have an idea of what they can expect. And then, you know, it cut down a lot of the time and expense and hassle of them as providers and us as senators trying to figure out who's more important than the other people. And so maybe there's a way, maybe there's not. But I think this is a good start and a way to kind of bring everybody to the table and figure out what we can maybe all agree on. Maybe there's a way forward. Like I said, Maryland and Oregon have figured it out. Maybe there's some way we can too. I think it has to take into context with the provider rates, maybe with surrounding states or like-minded states, what our fiscal revenue is going to be like, you know, in the future, and then what we think is lacking maybe in provider rates currently and in the future. So that's what I'm kind of hoping to hear maybe from a lot of the people we're bringing to the microphone today to talk to, and maybe have us ask some questions, and maybe there's some kind of formula we can kind of figure out here coming up. So any questions? Yes.
I have a couple of questions, if I might, sir.
Yeah.
Does your plan also have a provision for avoiding a governor's veto?
I don't know. No.
We might want to work that one in. It's kind of the final line.
So we'll make it veto proof. Yeah.
Make a veto
Yeah.
proof, you know, somewhere, I don't know how, probably by votes. Second question I have has to do with NCSL. I know we've used those, we use them a lot of times. I'm always curious, sometimes they say with auditors, you need to change auditors about every 5 or 7 years just to make sure that you get a new fresh look at it. We've used NCSL for so long. You know, I'm looking at the same going to the core. How much confidence do we have in NCSL? And that's kind of an open-ended, I'm sorry for that, but then I have one follow-up question.
Sure. Well, I think because of their history and their involvement in legislative, you know, in states' legislative issues, I think that they're somewhat reliable. I think we can use as maybe some advice on maybe an approach, kind of what we're looking at. It doesn't mean we have to go with everything they say. I think it's up to us to determine what we think is right. But
I always get nervous when someone has a de facto kind of a monopoly across the country. They seem to be held the monopoly on that. That makes me real nervous. But the other one, will we be talking in it today about fiscal notes? Because I think this, well, I want to say last regular session here, we had, I think it was first 5 that came in with a cost plus proposal for their agency, which we were not able to accommodate, I don't believe. I don't know that it got out of committee, but I'm just talking about the fiscal note on any and all of this. Will we get some? Because that seems to be the killer when it gets to the floor.
sure, I think that obviously has to be taken into account. And I think the fiscal note, along with future revenue growth, I think it makes a big deal too. Like if we're looking at, hey, we're having a great next year or next 2 years, we can actually afford to pay providers adequately. Or if we're having a bad couple of years, maybe like 2017, we might have to hold off and then hold on provider rate increases or possibly decrease them a little bit. You know, because if we can't afford other kind of aspects of government, we may not be able to afford this as well. So I think all that has to be taken into context.
I appreciate you bringing this forward. I think it's a healthy subject.
Yep, thank you. All right. Thank you. And I'm actually going to sit back in the chair so I can ask questions too. If that's okay. Thank you. And I'll be here to close. Okay, so first, let's welcome Cindy Cadavy from the Nebraska Healthcare Association. Welcome.
Good morning. Good morning, members of the Health and Human Services Committee. My name is Cindy Cadavy, CINDY-KADAVY, and I'm Vice President of Policy and Reimbursement for Nebraska Healthcare Association. On behalf of our more than 400 nursing facility and assisted living members, I'm here to provide comments on LR 392. We appreciate Senator Chairman Hansen holding this hearing and working to find a rebasing approach that works for all healthcare providers. As we represent both nursing facilities and assisted living communities, I wanted to start first with comments on nursing facilities. At 60%, Medicaid is the main payer for nursing facility care in Nebraska. Medicaid pays nursing facilities a daily rate or per diem, which your handout explains includes 24-hour skilled nursing care and a range of other services. The Medicaid rate setting methodology for nursing facilities is probably one of the most complex and multi-layered. However, this is for good reason, and any changes should be carefully considered because even a small change can impact residents' access to care. The current methodology incentivizes investment in the quality of care and in capital improvements. For example, paying one rate for nursing facility care may sound good in theory, but it can mean individuals who have higher needs have a difficult time accessing care. Although nursing facility rates are determined based on a facility's costs, I just want to be clear that the reimbursement does not actually cover the full cost of the care. Nursing facilities submit annual cost reports to Medicaid that are audited with costs disallowed and other costs limited by caps. During a rebasing year, each facility's rate is recalculated by Medicaid following a very specific methodology. For several years, Medicaid rebased nursing facility rates annually, but just prior to the pandemic, this was changed to no more than every 5 years. If there is additional funding available, rebasing helps to ensure Medicaid reimbursement gets closer to the cost of care. However, as we saw during the pandemic, several factors can change costs significantly from one year to the next, such as workforce challenges and increased regulatory requirements. One of the biggest cons to rebasing on the nursing facility side is if there is no increase in funding appropriated, rebasing only moves the money from one provider to another. So the pizza remains the same size, it's just sliced up differently. Switching to assisted living, Medicaid pays for assisted living through a waiver program, and it's estimated that Medicaid pays for approximately 10% of Nebraska's assisted living services. Medicaid currently pays only one flat rate for assisted living care that is adjusted by rural and urban. That rate was established more than 20 years ago and has only increased when the legislature approves a provider rate increase. Your handout shows the Medicaid rates compared to the cost of assisted living care over time. Assisted living facilities, oh, I apologize. Sorry, apologize.
You can continue, it's fine.
Okay, thank you. Sorry, prepared for 5. Assisted living facilities are not required to submit cost reports, and the only cost study was commissioned by the department in 2022. The final report for this study was released in September 2023, and it recommended Medicaid increase the assisted living rates and remove the urban and rural adjustment as they found no difference in costs. These recommendations have not been implemented. As assisted living providers do not currently submit Medicaid cost reports, and for many, Medicaid is not the main payer, the main con of rebasing would be the administrative burden and costs associated with needing to complete cost reports. And then just one more point, if there's no additional funding, rebasing just moves the money around from one provider to the next. Thank you for the opportunity to offer comments. I'm glad to answer any questions.
Thank you. Are there any questions from the committee? Senator Walls.
Thank you. Good morning. Thanks for coming here today.
Sorry.
I don't remember how many nursing homes have closed, even in the time that I've been here, but I know it is many, 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 too many. So I'm wondering if you can just give us an overall picture of where our senior citizens are going once their nursing home is closed, where they're going, the quality of services that they're receiving now, how much it costs. Is there a difference now? Are we paying more because of the closings? And just an overall picture, overall level of care, quality of care, what's going on since those nursing homes have closed.
And thank you, Senator Welch. And you're right, we have had a number of closures. So over the past decade, it's almost 100 nursing homes and assisted living facilities have closed. The majority, especially for nursing homes, have been in rural communities. You asked where they go. So residents, if there's a closure, residents are always given a choice of where they would like to relocate. And typically it's as close as possible to their current community. The hardship is for that resident. And then if they have any family or a spouse in their community, it just means longer travel time to have that visitation, which we know ties to their emotional and physical well-being. So it is really hard to see those closures. Typically, there's a combination of factors that contribute to the closures. Medicaid rate not covering the cost of care. So if you have a balance of payers, typically those paying privately will make up the Medicaid gap. So you may be able to sustain operations. But as more and more people spend down their resources, more and more are going on to Medicaid, so that Medicaid population increases, which puts a financial strain on nursing homes. The other thing that we've seen happen in rural communities is an overall migration of working age staff to the more metro areas. So most recently, one of the biggest factors has been just availability of staff to work in those facilities.
Yeah. Well, number one, is the fact that somebody has to move out of the community that they've worked in their entire lives and they're away from their families. That should not ever, ever, ever have to happen. I don't know if you have any information on this, but I drive through communities in rural areas all the time. And I know that, in several of those communities, the nursing homes have closed. And it seems to me that once that happens, you see the community deteriorate. It all almost becomes a ghost town. Do you have any just feedback for me on that as well?
Yeah, so we've seen the same occurrence, and a lot of times the nursing home is the main employer in that town. So not only does it provide care for those seniors who tend to be the people living near that community or in that community, but it also provides employment for the people in that community. So yeah, there's a number of situations I could go through that where it has contributed to the town not being as viable as it was at one point in time. So
Thank you. I appreciate you being here today.
Yes, Senator Reed.
Thank you, Chairman. Recently, CMS had some regulations out that would require nursing 24 hours a day, 7. And I know Nebraska is one of the states that said we won't comply, we can't comply. Do you have any update on that? I haven't heard anything about it recently.
So you're correct. The CMS published minimum staffing final rule for nursing facilities, it would require 24-hour RN coverage in every nursing facility. Right now, there's a requirement for nursing facilities to have 8-hour RN coverage 7 days a week. And some of our rural communities struggle to even meet that requirement. So let alone trying to find the nurses available to cover 24 hours. So that is due to go into effect in 2 years. So May of 2026 for urban facilities, and then in May of 2027 for rural communities. Just where those nurses are to be found is a real mystery. So there is legislation in Congress that would stop that implementation or slow it down or ask more questions. A lot of that is either supported or was introduced by our Nebraska delegation. So there's legislation that's active in Congress. Our National Association has also filed a lawsuit to try to stop the implementation. It was introduced in the federal district court in Texas. So that is pending, that legal action is pending. The Supreme Court did change the ruling on the Chevron case, which initially allowed the regulatory agencies the ability to interpret statutes in the way that they felt was best. And so that was overturned because CMS issued this mandatory or this mandate, unfunded mandate, through regulations, not through legislation. So, we're hoping our chances are good. It's not that we would love to have more staffing. It's just where are those people to be found?
And how do you pay for them?
And how do you pay for them? Yeah.
Okay. Thank you very much. Thank you, Chairman.
Yes, Senator Ballard.
Thank you, Chairman. Thank you for being here today. When was your last rate increase from the state?
So this past fiscal year, there was not a provider rate increase because, well, there wasn't for anyone, but there was an increase. So our providers came together and decided to make a slight increase in our provider assessment. So that would bring in more, it would leverage more federal dollars to help with those rates. That was a hardship for some of the rural communities just because you're paying out and you can't be guaranteed that you'll get the full amount back. So that's what was done most recently. So this last year, there was not an increase.
And then one more question. So the $2,000, almost a little over $2,000 between your cost and your reimbursement, is that absorbed by the facility, or does that go on to the patient?
So I think you're looking at the assisted living chart, it looks like.
Yes.
So what happens there, and that's the reason the availability of assisted living for people on Medicaid is pretty sparse. So what you have a lot of times is people, the only option is to go to a nursing home, which is more expensive. But right now what happens is assisted living facilities, those paying privately will supplement the Medicaid rate. So you have to increase your private pay rate. My parents were in a long-term care facility paying privately, and they saw their rates increase dramatically every year. So I tried to tell them, you're helping out others as well. But it just means they'll spend down more quickly.
Thank you.
I have a couple questions.
Okay.
And this is one I might pose to quite a few people. Even though I know a lot of industries might say they're currently not being reimbursed appropriately, but putting that aside, the idea of a universal kind of formula almost for provider rates, does that sound more attractive to you compared to what we're currently doing now?
So on the nursing facility, our members would say no. There was a proposal a number of years back to pay one rate for all nursing facility care. The problem is you have people who range in care needs. And so if you're paying like an average rate, then those individuals who have higher care needs, it can be really difficult for them to access care because you're losing a lot of money on those individuals. So like the nursing facilities methodology, like I said, is one of the most complex probably, but it really is for a good reason. And because it does incentivize investing more money in staffing quality of care and investing more money in your facility. So you take away that incentive, it's not there anymore. So on the nursing facility side, it would not be attractive. On the from our members' point of view, on the assisted living side, they are currently paid a flat rate, and it really has not seen a significant increase in the past few years. So it could conceivably, depending on what the rate was, could conceivably be more attractive on the assisted living side.
Okay. Usually, because you have to rebase, you guys rebase every year?
On the nursing home side, we used to. Now it's no later than every 5 years. So the last we rebased right before the pandemic, and then it was 4 years gap before we rebased again for nursing homes. Assisted living have never done a rebasing. They don't submit cost reports, so that's not happened. But there was a cost study done by the department that made recommendations, that looked at cost reports and made some recommendations.
Is the CMS requirement, is that every 5 years?
It's not a CMS requirement to rebase or to even pay based on cost. I mean, some states don't pay that way.
Okay.
Nebraska has, so.
And then do you take into account new technologies at all when figuring out new costs?
Yes, so that's when the nursing facility submits their Medicaid cost report every year. There are certain allowable costs. Certain costs are unallowable, like administrative costs over a certain level, things like that. So if they adopt new technology, that can be included in their cost report. But what happens then is Medicaid basically takes an average and puts a cap. So if you spend over the average amount, you're not going to get reimbursed in your rate. But so that's where it's based on cost, but all your costs aren't covered. So.
I had one question on here. Is the current rate methodology fair to smaller rural skilled nursing facilities?
There's good and bad, and I've been around long enough that I've seen the nursing facility methodology change somewhat. I don't know that nursing facility providers love the current methodology, but they're able to plan within that. And so there's always, with rebasing and with our methodology, there's always people who see their rates go up, and there's others who see their rates go down or not up as much, depending on how much money is available. So if your rate goes down, you're not happy with it. If your rate goes up, you may be happy with it.
Okay.
On assisted living, it's just the same statewide.
One of the factors I always thought if we were ever to go to a more kind of universal approach to provider rates is you'd have to include some kind of form of inflationary, concept. Is that included at all when you do rebasing or anything?
It isn't. Medicaid applies what they call an inflation factor, but it is not connected at all with inflation. It's designed to be a controlling factor so that they project what nursing facility spending will be in the upcoming year, and then they apply a percentage to each rate to make sure that the spending doesn't exceed the appropriated amount. So it's just so if you see that nomenclature, it's misleading. It's not an inflation factor.
Okay. All right. Thank you. Any other questions from the committee? Seeing none. Thank you for coming. Appreciate it. All right. Next up is Chase. Is it Francel? Okay. CEO, Mid-Plains Center in Grand Island, Nebraska Association of Behavioral Health Organizations. Thank you for coming.
Right. Thank you for having me. Good morning, Chairman Hansen, members of the Health and Human Services Committee. My name is Chase Francel, CHASE-FRANCL. I serve as the president and CEO for Mid-Plains Center. We provide an array of outpatient and crisis residential services. We're headquartered out of Grand Island. Just 2 decades ago, Nebraska was ranked 49th among states in Medicaid reimbursement rates for behavioral health services. Our agencies statewide were under-resourced, we were understaffed. Staff we did have were underpaid and undertrained. Unfortunately, the result was countless individuals in our communities that were left hopelessly underserved. In those days, encountering circumstances that to many businesses would represent just a minor disruption were potentially catastrophic for us. I remember vividly conversations at agency meetings and gatherings where conversation would inevitably drift towards which agencies had recently closed their doors or were in serious trouble. The history of Mid-Plains Center just 15 years ago is that we too were once an agency that had to take out loans against our sole piece of property just in order to make payroll and keep our doors open. We're grateful that today, in large part due to the foresight and commitment of our communities and the legislature, we think the value and the importance of behavioral health services as an upstream solution to so many of our social and economic challenges has become better understood. We have made an investment in our behavioral health system, in our rates, and in our workforce. And I think the importance of this investment was never more clearly seen than when COVID unmasked that need for greater mental health and substance use treatment options than ever before. As behavioral health conditions across the population spiked from 1 in 5 to 1 in 3 Americans in need of our help, our system showed the ability to quickly adapt and play a crucial role in supporting Nebraska's nation-leading response. Today, our system continues to reduce the burden on more costly systems, such as emergency departments, law enforcement, and our corrections system. Research continues to demonstrate that when communities have access to behavioral health care, we see reductions in homelessness, and crime, and unemployment, along with improvements in school performance and workplace productivity. Simply put, communities that have strong behavioral health systems are safer, healthier, and more economically resilient, all which are vital functions of the government you all are asked to oversee. So I stress these benefits today to say thank you for the wise investment that's already been made into our system. The work our staff do each day is equal parts challenging and rewarding, and your continued support is crucial in allowing us to meet that challenge. So my support for LR 392 is in recognition that even hard-earned gains can be easily lost. Organizations that comprise NABHO recognize we're rate takers, not rate setters. We don't have the ability to simply build a better product or add another feature or find a better market. We're tasked to serve whoever needs us, wherever they are, as best we can, regardless of their ability to pay. And that's simply our reality. We've signed up for this. But it also explains why we have to come to the legislature year after year, uncertain but hopeful of the continued support necessary to allow us to continue our mission. Nonprofit organizations such as mine operate on extremely small or even negative margins that have to be supplemented by grants or by fundraising. So any fluctuation in costs or funding quickly becomes destabilizing. And with so few alternatives to our business functions, we lose sleep in an effort to protect the balance between money and mission. That's why we feel LR 392 is so important. We ask for your support so we can plan accordingly and support our business, and so we're available for folks when they need us. Thank you.
Thank you. Yes, Senator Reapy.
Thank you, Chairman. I tried to scan over this real quickly, and it said in here that 20 years ago, Nebraska was ranked 49th. Quite frankly, with the way healthcare and life has gone, 20 years is more than a lifetime for many people. So I sort of dismissed that. Where does Nebraska stand today?
Today, I believe we are in the top, we're in the top 10. I believe we may be in top 7 or top 5 of behavioral health rates, kind of depending how you look at it.
Good. I move we adjourn. Okay, thank you.
Senator Ballard.
Thank you, Chairman. Thank you for being here, Chase. Can you expand on the staffing shortages and how that impacts reimbursement rates?
Yeah, certainly. So as we look at staff, the biggest challenge right now certainly is staffing, is recruitment, is retention. My background is as a therapist. I look at when I entered the workforce as a therapist about 20 years ago versus what we're paying now. We're about 50% more that we're having to pay now just to attract an entry level therapist. For some of our services, we're recruiting nurses, and so we're recruiting against hospitals that are in it's a more profitable, maybe in some situations, sector than we are. And so it really is a challenge. As our organization 2 years ago, we were down to 58 staff. Today we're up at 80. And so some of those have been some of the workforce reinvestment that's come. Those are one-time grants. I think a lot of the ability for us to move our system forward has come from those, whether that was COVID dollars or ARPA dollars, different things that came through that. But I think long-term ongoing, as staff costs rise, as insurance costs rise, as new technology costs rise, all those things that require us to stay current, to provide a decent level, quality level service, we're like everybody else. It continues to be challenging. And when we don't know that those rates are going to be there, it's hard to know where you make those investments. So you're not building new programs that then you're shutting down in 1 or 2 years because those even incremental increases aren't there to support it.
And staffing makes up a good, what percentage of your overall expenses?
For us, it's over 80% of our budget is staffing costs.
Okay,
Yes.
thank you.
Yeah.
Any other questions? Yes, Senator Reapy.
I do have one question. I know in the state of Nebraska, we have 6 regional mental health things. One of my primary concerns with mental health is there doesn't seem to be a lot of coordination. We see, I mean, I've been in the healthcare business for like 40 years, and there's things that pop up that have been there for 10 years. I've never heard of them. My question gets to be is how does your organization fit into these 6 regions that are, I understand, there to try to coordinate, facilitate, to maximize service delivery and for obviously access and affordability.
Right. No, great question. So we do. We're part of Region 3. We have
Okay.
contracts with Region 3. We provide some services as it pushes further out west, Region 2, Region 1. We have some folks, particularly our crisis stabilization detox services, serve a lot of folks from there. We receive about a third of our budget comes from the regional system, so a little over $2 million of our roughly $6 million annual budget. I would push back or disagree with the assessment, at least from the region standpoint. It is some of the best coordination. If we could serve only region folks and not have to jump through the hoops of Medicaid and private insurance, I would do that 7 out of 7 days. Our regional behavioral health system, what they do a really good job of is understanding, because they have representation from the counties and from the communities, of knowing what those needs are. And so where a system, a payer like Medicaid has, a set array of services that falls into Medicaid, regions can identify problems, they can find solutions, design programs specifically to meet those other needs that fall in what can be pretty significant gaps from what Medicaid pays for. So it's a great experience for us. I think we have one of the best regions in the state. I'm yet to meet a bad one, but we're really pleased and really happy with the regions. It's a harder system when they get rate increases. Recently, they don't get additional funding either. And so it actually decreases their capacity to be able to serve folks. We get paid more, but as was shared with the previous testifier, that overall size of the pizza is staying the same size.
May I ask the question? You rang a bell for me when you talked about counties. Do counties consistently, because I assume, tell me if I'm wrong, cover more than one county? You cover multiple counties.
We do, yes.
So do all those counties consistently contribute, and do some high, some low,
Yep.
or do you have
Yep.
a standard?
There is a percentage match with their region based on population.
Based on population or
Correct.
based on who gets services?
Based on population.
Okay,
Yes. Yep.
okay, thanks.
So for us in Region 3, Hall County being Grand Island has by far the largest share of matching dollars that goes to Region 3 that then gets distributed back out for services.
Okay, thank you.
Yes.
I may have missed it, but how do behavioral health providers develop the rate methodologies?
So a lot of those are handed down to us. Medicaid services set their rates. We come and advocate to appropriations when we feel there's concerns, questions that those are too low. The regional behavioral health authorities, the regions will at times initiate cost studies when they have questions or concerns that rates may be extremely low. About 12 years ago, I was the executive director at a halfway house, and we were paid, I believe the rate was $63 a day for a residential service. It cost us closer to $110 a day. And so we were required to do fundraising, participate in United Way just to make costs. We had years of breaking even was reasons to be doing cartwheels down the hallway. The regions identified that. They looked and did a rate study, and that boosted that number up to like $115 a day, which allowed us then to invest and even in some cases start looking at expanding services and being able to meet other needs that we saw that weren't being met in the community. So that looks at our true cost of providing services, doing time studies on your staff, submitting expenses, a pretty thorough process.
Is the majority of your funding for behavioral health providers coming from Medicaid, or is it?
For us right now, certainly since Medicaid expansion, we're about 40 to 50% Medicaid. We have some services that are funded through an expense reimbursement process, which is region funded. We get a little bit of Medicaid, but about 2 to 3 million, depending on our services mix that year, as Medicaid.
Okay. Similar question. So do you think behavioral health providers would benefit from kind of a one rate methodology approach?
Yeah,
as
we
opposed to what we
absolutely
do now?
we absolutely would. Looking if we're talking about doing like a percentage increase year over year, that would be something that would very much help us be able to plan as we are doing our budgeting. We don't know. We start our budget planning in January. We don't know what our reality is going to be. Things move so quickly. Services that are sought after may suddenly not be sought after. And so I think there would be a huge benefit for us knowing what's coming so that we can budget responsibly. We can be prepared and make those plans.
That seems like that's been the consistent theme like the 6 years I've been here in an HHS, when we hear from providers, is like, it's very difficult for them to plan, because a lot of them have 3, 5 year, 10-year, plans when it comes to their business or,
Right.
The industry. And it's hard to know if you're going to get anything from one year to the next. I know as a provider myself, sometimes when it comes to Medicare or Medicaid, we have no idea what it's going to be from one year to the next. We could go up 3% or we can go down 3%,
Right.
which is what happened to us this year. And, but federal government's a lot different than what we do here. But
Right.
So I think that would be one of the most beneficial things of having one rate methodology, so that people can actually, not just us from a budgetary standpoint, but from a provider standpoint, have an idea of what's coming down the road, maybe 2-3 years down the road.
Correct. Yeah, it's really about protecting. We really have made good gains that were desperately needed. I remember meetings where, in a 2 to 3 year period, there were 5 and 6 agencies that were closing their doors, and then no one's willing to step up into those gaps, which just pushes people into higher, more costly levels of care. They end up spending more time in corrections, in hospitals. And that's where really recognizing behavioral health is an investment. We are one of the cheapest solutions to the challenges that Nebraskans are facing out there.
Okay. Do you know the last time behavioral health providers are rebased?
I don't know the last time we did a full rebase.
Okay.
I'm sorry.
Okay, I think that's pretty much the questions I had. Any other questions from the committee? All right, seeing none.
Right.
Thank you very much.
Thank you.
All right. Next, we have Joe Donlinger from PACE Region 5. Welcome.
Thank you.
You can begin whenever you like.
Okay. I'll follow the theme of writing too long of a testimony,
Yep, that's
so I'll
fine.
try to
That'd be
read
good.
quickly. Okay. Chairman Hansen and members of the committee, thank you for the opportunity to testify today. My name is Joe Donlinger, JoeDondlinger, and I'm the Chief Financial Officer of PACE, Nebraska's largest provider of home and community-based services for individuals with intellectual and developmental disabilities. We are honored to serve approximately 800 individuals in Southeast Nebraska. I am here to highlight the urgent need for the study of rates paid to developmental disability providers like PACE. Our current system, which relies on data that is now a decade old, is insufficient to meet the needs of the individuals we serve. I'd like to discuss 4 key points today. The first is an outdated rate setting model. The rates we currently use were developed with a rate model from data from 2014. The handout I provided today shows the construction of the rates in the current model. The model was implemented in 2019, and it has not been substantially updated since. This is concerning because the cost structures for services such as wages for DSPs, direct support professionals, have significantly changed over the last decade. For example, the model assumes a base wage for DSPs without accounting for overtime. This is simply unrealistic, especially considering the workforce shortages and additional hours DSPs must often work to cover shifts. The model also lacks funding for critical areas like training cost. While the rate model includes some funding for initial training determined by a provider survey in 2017, DHHS has since mandated the usage of one system for emergency and safety interventions, or ESI training, the MANT system, and that costs providers hundreds of thousands of dollars per year. This gap places additional financial strain on providers like PACE, as we must absorb these training costs without reimbursement from the state. Second, federal mandates on rate reviews. The Center for Medicare and Medicaid Services, CMS, have clear guidelines that require states to review their rate setting methodologies at least every 5 years. I've included in the handout the reference to this in my testimony today. CMS mandates that rates must be reviewed to ensure they are adequate to maintain both access to services and the quality of care provided. Nebraska has not conducted a full review since the 2014 data was collected, putting us behind federal requirements. The consequences of neglecting these reviews are real. The quality and sustainability of services for individuals with developmental disabilities are jeopardized without appropriate funding. Third, issues with using cost reports for rate setting. While cost reports play a role in rate setting, they present their own set of challenges. The current cost reporting process does not capture data on capital investments, meaning essential investments in infrastructure and technology, critical to delivering high-quality care are not factored into the rate calculation. Instead, these reports only reflect a simple comparison of payments and expenditures, showing a surplus or deficit, but omitting underlying capital needs for providers. Additionally, cost report accounts often need to be allocated across multiple categories or rates factors in the rate determination process. This can lead to misrepresentation of actual cost. Without the proper capture of data on capital investment and clear allocation methods, the rates will continue to fall short of what is needed to support quality service provision. And then lastly, I'd like to share APACE's current financial picture to illustrate the precarious position that we find ourselves with the existing rate structure. We are anticipating this year a 1.7% decrease in revenue from our last fiscal year. Although we finished our last fiscal year with a 1.6% surplus, the reality is that this margin is razor thin and unsustainable. In fact, through August of this year, we've already experienced a deficit of $102,000 or negative 0.1%. These trends are unsustainable, and without a change in the rate model, providers across the state will continue to struggle, jeopardizing the care of those who depend on us. In conclusion, in closing, I strongly urge DHHS to initiate a comprehensive study of the rates paid to developmental disability providers in Nebraska. Updating the rate setting process is essential not only to meet federal requirements, but also to ensure that individuals with intellectual and developmental disabilities receive the high quality care they deserve. Thank you for your time. Happy to answer any questions.
Thank you. Are there any questions from the committee? Senator Reapy.
Thank you, Chairman. A question I have, are you part of, I know the governor's talked about the waiting list. We've had it for 8 years, I believe, or something. Are you guys kind of at the end of that? I'm not saying you're going to fix it, but you're part of that. You're the ones that we go to have openings to try to move people through that.
Correct. We're service providers that would be available to serve people who are on the waiting list.
Who else in addition to APACE provides a like service or the same service? Is there anyone out there?
Yeah, Duet, Mosaic, Integrated Life Choices. The testifier right after me is the chair of our Service Provider Association. So she may be able to give a bigger list.
Okay,
Of all of
so
our
she'll
members.
have a broader picture of
She
it.
will.
Okay, we'll save the real tough questions for her.
All right.
Okay, thank you. Thank you,
You bet.
Chairman.
Senator Day.
Thank you, Chairman Hansen, and thank you for being here today. I appreciate you mentioning several of your points, especially about being out of compliance with federal mandates, and then also the razor thin margins you guys are functioning on. Have you had a chance to look over the preliminary budget that has been proposed for the upcoming year?
I have.
Okay, so we're potentially looking at hundreds of millions, if not upwards of $1 billion in budget cuts this upcoming year, particularly to the Department of Health and Human Services and specifically Medicaid. Do you see any realistic way of making provider rates better for providers while also cutting hundreds of millions of dollars from the Department of Health and Human Services? Like, what would that do to your organization? Do you see that as being problematic for your organization?
And I suppose it depends on what strategy DHHS uses for the cuts. In the modifications I saw, there were cuts to optional Medicaid services. There were provider rate decreases. So what would be most detrimental to organizations like APACE would be the provider rate decreases.
Okay.
Do I see a way to cut hundreds of millions and do provider rate increases? I don't know. That's a difficult question. It would be very difficult to do both.
Okay, thank you.
Senator Walls.
She asked my question.
Okay. Senator Beller, did you have your hand up? You did? Okay. Are there any other states that you look towards that do a good job with rate methodology? Or
I believe you should save that question for the next presenter because
I have like 20 questions for you.
You do? Oh, okay.
No, it's
I'll
joking.
keep deferring to her. No, I'm I want to say that I'm an expert in other states. So I know our trade association has done that sort of research. So.
Anything else I can ask you? No. Okay, nope, I think that's it for me.
All right. Thank you.
Yep, thank you.
Thank you.
All right, next up, Alana Shriver, Nebraska Association of Service Providers.
Chop down a tree for you guys today.
Welcome.
Good morning, Chairman Hansen and members of the committee. My name's Elena Shriver, ALANA-SCHRIVER, and I'm the Executive Director of NASP, which, as Joe mentioned, is the provider association for the home and community-based organizations that support individuals with intellectual and developmental disabilities. So thank you for the opportunity sorry, I'm like battling some plague, but I promise for the future speakers, I'm on antibiotics and steroids, and according to my doctor, I'm past the contagious stage. So DD providers are good stewards of state dollars. As Joe mentioned, we do annual audited cost reports down to the penny of how we spend state dollars. According to the state auditor, DHHS cannot say the same, but often they're given more credence than we are since they've got .gov at the end of their email addresses. So in the massive handouts I've given you, I want to start with the case for inclusion, which just came out this month. And I've marked page 7 for you. I just want to bring your attention to, often DHHS will say, well, our wages fall right in the middle nationally, so we're not the worst. But that does not take into account our competitive labor market with our unemployment rates here in Nebraska and what $15 an hour will buy you in our market. So as you can see, our turnover, as I quote, is the whopping worst, coming in at 59.1% turnover rates, and the national average is 40% for direct support professionals. The State of America's Direct Workforce Crisis, which is the next one that came out from NCOR, we should be getting 2024 soon, but this is 2023, basically just says that IDD providers nationwide, about 95% are experiencing staff shortages and 77% are unable to take new referrals. I've also given you a one-pager that shows you what our current rate methodology supports as far as wages goes, which is about $15.56 an hour. We would ideally like methodology that supports DSP wages at 150% of Nebraska's rising minimum wage. Beatrice State Development Center, which does similar work, has increased their state employee wages, so they're in the living wage category. As you can see, according to MIT, the living wage for Nebraska right now for a single adult, no kids, is $20.12 an hour. So when you throw family into that, we are not even close. And when you're living at poverty level, you're pulling from state dollars for Medicaid for yourselves, Title 20, ADC, SNAP, all of those things. So the staffing crisis is not unique to Nebraska, but we do seem to be the only state pretending it doesn't exist. For example, Pennsylvania recently announced that they're also working on eliminating their DD wait list. About the same time, Governor Pillen said we're going to do that here too, except in Pennsylvania, they know that you cannot eliminate the wait list without investing in your workforce. So they are investing about $700 million just to bring the first 1,500 individuals off their wait list. This includes a 12% provider rate increase. Our wait list currently has almost 3,000 people on it. So $700 million to do half of what Governor Pillen says we can do for 18 million here in new dollars, which I just don't think is possible. I did request data from my colleagues in other states. I only had a 2-day turnaround, so what I've got is here for you. So Kentucky's recent rate study says they are jumping from $13 an hour to $23 an hour. Missouri's investing $580 million to bump wages from $16 to $22 an hour. Oklahoma just did a 25% rate increase. Virginia, also trying to eliminate their wait list, increase rates over 50%, and they're still behind on their elimination timeline. And Minnesota adjusts for inflation every budget cycle, which they have a 2-year budget cycle like ours. Nebraska did a recent rate study for the aged and disabled waiver. We have 5 different waivers here in Nebraska, but they're not really parading around that rate study for you guys because it does recommend significant rate increases as well as tying those rates to the consumer price index. Last session, we gave you a study from Nebraska's leading economist, Goss and Associates, proving a positive return on investment for the state when it comes to these services. So you guys have more than enough data and the common sense to identify the problem as well as the solution. DHHS leadership has come to me recently, I'm talking like the past 2 weeks, asking how we can get more providers to take on the new family support waiver, which, if you're not familiar, is bringing kids into the DD system. They want to increase intermittent support services, which helps people be more independent in their own homes, as well as we need more group homes in Nebraska. But so they're asking like there's some secret on how we encourage providers to provide more services, but there isn't a secret. We just, our rate methodology just does not pay a living wage. So I have providers who are operating in multiple states telling me that they just can't focus on Nebraska right now because the post-COVID economic realities are being acknowledged in those other states and they're not being acknowledged here. So Senator Day and Walls brought up the recent Open Sky Policy Institute report of the projected budget, saying provider rate increases could be cut 5%. At the same time that DHHS is asking me how providers can expand services and capacity. So Tony tells me all the Director Green tells me all the time, provider, all you come back for is rates. But I have to disagree. I think it's actually the administration and unfortunately too many of your colleagues who see disability services as nothing more than the bottom line. And we're the ones coming with the human element year after year. I'd love to bring innovative ideas and remote supports and AI and how do we alleviate staff shortages through technology, which currently isn't even a waiver benefit. But we're fighting for solvency here. And when I think of disability services, I think of my son and his quality of life. So for me, it's the state who commodifies the people that we serve, and it's the state who focuses on rates. Well, we're begging you to see the human element of these services. So I hope you take the time. I know this committee is the Human Services Committee, so I'm not trying to lecture you guys in particular, but just understand the power that you have. And I know it's a tough session, and like you mentioned, Governor Reapy, we're facing a possible veto on good stuff here, but I hope you have the fortitude for that fight and to stick up for Nebraskans, because ultimately it's the state's responsibility to support people with disabilities. And we're just trying to partner with you on that effort and do it at a more affordable rate than the state institution costs to do the same work. So happy to answer any questions that you might have.
Thank you. Senator Eby.
Thank you, Chairman. Would you repeat for me, you talked about one state committing 300 million. I sort of mentally just went blank.
Sure.
That big number. Which state was that?
I believe the first one I mentioned was 700 million. So
Oh,
Pennsylvania
700?
is doing 78 million.
Which state was that?
Pennsylvania. So they're and I've given Bryson a lot of different states and connected him with those state association execs in that state as well. But they're doing 78 million towards the individual service budgets. So each individual, based on their level of need, gets a budget. So for those first 1,500, they're going to get 78 million just for the people. And then they did $109 million stabilization payment for providers based on their last 6 months of billing claims. And then an additional 12% provider rate increase permanent across the board. And then Missouri's doing $580 million. Otherwise, I just got percentages. So Oklahoma just did a 25% rate increase, and Virginia did over 50% rate increase recently. And
I like hard numbers as opposed to percentages. So
yeah, I can try. I can do my best to get those for you.
580 million and 700 millions. Maybe a little out of our price range, but
Yeah.
thank you, Mr.
It'd be
Chairman.
nice if this was cheaper. It just isn't.
Senator Miller. Thank you, Chairman. Thank you for being here. Does Nebraska do a good job of pulling down federal funds for DD services?
Sometimes Sometimes I don't know if they see all of the opportunities to do so. So for example, there was the recent general ARPA pot of money for the state, but then there was a home and community-based services, which was about $90 million. So they're trying to get us another kind of stabilization payment. So for example, they asked for $6 million to parcel out to providers as a stabilization payment, maybe around January. But we had to suggest they try to get the federal match for that. It kind of hadn't occurred to them to do that themselves. So I think they're open to it when that idea is brought to them, but we have to sometimes suggest that.
And do other states, do they have innovative approaches pulling down those federal dollars apart from just a general fund impact?
I would say other states do a much better job of finding ways to not overregulate and to use those remote supports and technology to increase independence. So, for example, we are required to do electronic visit verification, right? So if I'm going to go into someone's home, I have to go through this app that the state has chosen the vendor for, and our workers clock in and out from the home. So it captures the GPS. You get the person that you're supporting signature to prove you were there for this certain amount of time. GPS, as we know, in Nebraska isn't going to work in every rural area. My parents' house, you can't GPS their farm. You'll end up in the middle of a cornfield somewhere. And the technology just doesn't always work. We have a lot of storms. We have a lot of power outages. Verizon goes down, whatever. Sometimes the app itself is down for refurbishment, and we do 24-hour services. Sometimes you walk into a house and there's something happening and you need to step in and help right away. Or you need to go to a doctor appointment that day or something. You're not where that GPS is supposed to be. They're saying in January that if we don't have 100% perfect clock in and outs with the correct GPS capture, that they will not pay us for that visit. We can go through a 2 to 8 month appeals process where I'm paying admin salary time to try to get back $40 over a 2 to 8 month period, when the people who built the software are telling me 100% compliance isn't even possible. And so there's just a lot that comes down on us. And to answer a question, Senator Hansen, you've asked other people, I don't know if we could do a universal provider methodology because each different service industry has those different regs that come down on them, like the MANT curriculum Joe mentioned. Plus with group homes, we have to pay property insurance. Property insurance isn't following inflation. It's going way above. If we add kids with the family support waiver, your liability insurance jumps exponentially. So other states do a much better job of, oh, the Department of Labor says there's a new overtime rule for salaried staff. Let's automatically adjust our rates so you can pay those salaried staff that new overtime requirement. Oh, CMS is coming out with a new requirement that's going to cost money. Let's automatically adjust your rates so that you're not eating that at the provider level. So I would say other states are more responsive and more timely as new mandates come out.
Thank you.
Senator Repeat.
Thank you, Chairman. You talked about regulations, then you were saying that you mentioned unfunded mandates. Now, is that at the federal level? I mean, do we as a state have control over the regulations you're talking about?
Not if they come from CMS. CMS is federal, so we have to do that, Department of Labor.
But
that's
are there
federal.
some
But
regulations
yes, a
out there?
lot of the regulations are from Nebraska's DHHS, and they don't always follow their own rulemaking process.
You're kidding.
Sometimes, it's shocking, right? So sometimes we'll have like a provider decree. Like, for example, the electronic visit verification was a provider decree. You have 30 days, so you have to, so we filed an injunction trying to postpone. So they paused till January to try to get that tech in place, try to get training in place. And as part of that injunction we filed, DHHS submitted their brief saying, well, we have eminent sovereign immunity to do this because of our rulemaking process. But yeah, you didn't follow it. You didn't give us a chance for public comment. You didn't give a chance for those business owners to say why this won't work. So we're always open to work with them and find of course we want quality assurance. Of course we should be able, we should have to prove this visit took place. but let's be realistic and find a solution that functions from both ends.
You said file an injunction. That probably means an attorney involved, and that's probably not pro bono.
Nope, my budget's not big.
Thank you, Mr. Chairman. Thank you.
Yes. So considering the high turnover rate that we have that you talked about, why do you think we have such a high turnover rate? Is it wages? Is it regulatory environment? Is it they're not happy with their job? Have there been like any kind of
Exit surveys? kind of thing?
yes, yeah, ask
Yep.
them, okay, why are you leaving so much?
Yeah.
Kind of curious.
I think people come in because it's the type of job you do if you want to help people. Sometimes if you don't have personal experience, you may not realize how challenging the job can be. It is really fun, but there's difficult times. I mean, as a mom, there are days that it's like, it's a good thing I'm biologically programmed not to murder this person because I just can't take it anymore. And so you'll have challenging days. It's 365. You know, you're going to have to work Christmas. You might have to work Thanksgiving. You might get called in on your birthday, those types of things. But I think ultimately it comes down to you just can't pay your bills. And we have job coaches, right? That'll help people with disabilities find supported employment in their own communities. So if I'm getting $16 an hour and I take my individual to apply for a job at Menards and they get hired at $18 an hour, why wouldn't I fill out an application at the same time? Even if I love my job and I feel good about what I'm doing, if I can't pay my bills, it's just not sustainable. So we don't necessarily have a problem attracting people to the industry. It's just keeping them when life hits you.
Okay. And that's kind of what I was asking. Have there been any surveys or have you asked employees why they're leaving?
Individual agencies do that, and it's pretty much those same answers across the board. It's more challenging than they thought. The schedule's harder to manage. Intermittent supports, for example, that I mentioned, aren't super reliable because if the family, let's say I'm going to do respite care, which is like relief. So everybody's asking for the same hours. All families want evening and weekend respite care. It's hard to staff. And then maybe today we're on vacation as a family, so I don't need respite today. So I can't rely, as an employee, I can't rely on those hours. So you don't always know what your schedule is going to be. It's not super predictable, but ultimately it comes down to wages.
A question I was asking before, are there any other states that you know of that maybe do a rate methodology that you think is good, or comparing us to like maybe surrounding states that do something better?
I personally think we should just rebase on our state budget. So sorry, should have brought my water bottle up. Oh,
We blamed you to answer all the questions, so that's probably why.
give me 1 second. Thank you, Kirsten. Joe?
You're fine, take your time.
Minnesota.
Thank you. And I can ask you why if you want to explain. But just take your time. Yeah, take your time.
I can come back at the end too.
Okay. And that's just fine. Nope, that's fine. If we have any more questions, we can always ask you afterwards too. So,
Thank you.
all right. So let's move on to the next one here. Amy Reynoldson with NMA. Welcome, Amy. No. Thank you. Yeah, they mentioned also there might be somebody else representing NMA. So.
I'm obviously not Amy Reynolds' son, but, well, thank you, Chair Hansen and members of the Health and Human Services Committee. My name is Robert Wergin, Robert Wergin. I'm a family physician in Seward, Nebraska, and president-elect of the Nebraska Medical Association, which reflects approximately 3,000 physicians, residents, and students in the state of Nebraska. And I want to thank you, Senator Hansen, and the committee for introducing this study and for inviting input on the methodology for setting reimbursement rates for the Nebraska Medicaid program. I'm going to cut down on my comments to be respectful of your time here. But as you know, reimbursement rate methodology is complicated and has critical implications, and many times uses Medicare type reimbursement models for the Medicaid fee schedule. They use a resource-based relative value scale to set standards for the services provided, which also uses a relative value unit per procedures and what it would cost to provide those. That should include the physician work, practice expense, professional liability. And while Nebraska Medicaid has used this methodology, it lags significantly behind Medicare and commercial payers to the extent that it's difficult for our providers to do the business model with double-digit increases since 2020 in our staffing, supply, and insurance costs. So it comes down to creating access issues for patients, saying that they can limit the number of Medicaid patients they can see. Other than just investing additional funding into provider reimbursement rates, that we feel there may be other opportunities for Nebraska to explore to create approaches to how physicians are paid for patients covered by Medicaid through value-based care systems. And I'm going to briefly mention two models that have been tried by others. Shared saving contracts incentives providers to achieve cost savings while improving patient coordination and outcomes. A shared savings contract is an agreement between a healthcare payer and a provider to reduce healthcare costs by sharing the financial benefits resulting from cost savings. Providers are rewarded when they achieve cost reduction targets through smarter spending while maintaining certain quality benchmarks. For an example of this is a Medicare Shared Savings Program. It is a program that not only improved patient care for patients, it saved Medicare about $1.8 billion in 2022 compared to their spending targets for the year. The other method is care coordination, in which Medicaid and MCOs may be able to enhance physician reimbursement while improving care for patients and saving costs. Care coordination involves deliberately organizing patient care activities and sharing information among all of the participants concerned with patient care to achieve better and more effective care. Programs through Medicare and many commercial payers incentivize care coordination through care coordination fees, sometimes based on the complexity of the needs of different patients. However, these care coordination incentives have not been available currently under the Nebraska Medicaid or the MCO contracts. In addition to saving costs, improving patient care, these types of programs make it more attractive for physicians to provide care to the participating patient population. There is an ACO, Accountable Care Organization in Nebraska, that demonstrated these incentives and achieved through value-based payment arrangements. And it made their, not under Medicaid, but under Medicare, those patients more than twice as valuable to those patient practices as compared to covering Medicaid. That ACO demonstrated from 2017 January to July 2024, it achieved value-based arrangements, 31% reduction in hospitalizations, 13% reduction in emergency room visits, which are the high-end costs of healthcare delivery for these participating patients. There are other innovative models other than just increased funding that may provide incentives to create this access that this patient population needs and fit within the business model that patient practices have. Delaying access appears to save money, but if it long-term increases higher cost care, it won't. I appreciate this opportunity to testify. The NMA looks forward to working with the committee, DHHS, and the MCOs to ensure Nebraska's Medicaid program is delivering high-quality, cost-effective care. And I'm happy to answer any questions. There are other models I could mention too.
Thank you. Any questions from the committee? Senator Reapy.
I, of course, have one. Thank you, Chairman. Dr. Waring, good to see you again.
Good to see you.
Ms. Smith, when she was CEO of DHHS, shared with me on side one time that Nebraska has a relatively rich Medicaid program. My question gets to be is, rather than starve everyone, do you need to prioritize programs and maybe make sure that not to reduce the funding, but to make sure that you then make sure that you sufficiently fund certain programs, critical programs, much to the expense of maybe which ones are the, what I will describe as nice programs.
I think that it would be a model, and all businesses look at where is the best investment for return on investment. From my standpoint, in a rural area, it's hard to gain my practice, so to speak. They're your neighbors and that. So you just absorb the seeing patients under your cost and accept that. But in rural areas, it creates access issues is if you go under, if you can't maintain that business model. So I think access is key. And most of the studies, even in Medicare, found this to create access to care. And our state, I was part of the task force that created a patient-centered medical home project where people were assigned a medical home, and they saved the Medicaid program about $2.1 million over 2 years, which is not a huge sum in your budget measure, but it took about a year to get those practices up to speed. So I think, and how it created those cost savings, being a former hospital administrator, Senator Reapy, within ER visits and hospitalizations. The actual reimbursement to the physicians and clinic was actually a little higher because they were creating access for those patients to be seen and accommodated.
Any other questions, Senator Reapy?
Thank you. No, thank you,
Okay,
Chairman.
all
Thank you.
Are there already quality measures in place when developing a rate with MCOs?
I believe there is, although I don't know if they're incentivized, and I could get back to you on that. Amongst the private payers, there is Blue Cross Blue Shield and that in my practice. If you meet certain quality standard, you get a relative value-based payment at the end of the year to compensate you for. Even Medicare, I mentioned the complexity of patients will set the care coordination fees based on how complicated they are. And those are designed to help provide for the cost of setting up those programs within your office. Some clinics will say, well, I'm a good relative value base, I'll create value, but it takes motivation and incentive. It takes infrastructure to meet those criteria. But the short answer is yes, in the private sector, I know in my practice, we receive bonuses for meeting value-based payment.
Okay, now that's what you kind of alluded to a little bit here in your testimony. That's one of the things I mentioned in the opening is if there's some way we can kind of incentivize quality of care as part of a rate methodology. That would be nice to do. I mean, I think that's a little more effective and efficient care, I think, from a provider standpoint. So, and again, like what I mentioned before with NASP, is there any other states that you know that you look towards the NMA specifically, like saying, hey, we really like how their approach about how they do rate methodology or how they,
I don't have them there, but I know certain states have used some of these modalities to do it. There was one state that actually didn't work very well, direct primary care. Dr. Bliss in Washington State implemented a direct primary care program for the Medicaid program, and they had some administrative issues that didn't work. That's where they paid practices a monthly fee to provide the care and then some overarching cost for catastrophic care. But Washington State had that a few years. Several states have set, and I don't mean to be self-serving because I represent all physicians, it's primary care percentages. They say you have to spend 10% on primary care. Rhode Island did that, Oregon, that, and the insurers that covered private insurers as well threw a fit, said this will break us. All of them save money. When you create the access into a primary care coordinated care program, it goes back to hospitalizations, ER, and most of that, those practices were paid, went into the infrastructure it took to do that. So I know Oregon, Colorado, Rhode Island was one of the, Chris Collier was the one who had said about it. He's with the Millbank Fund now.
Okay. And I think that might be a part of this is how can we be more effective with better quality of care, where we might actually save the state taxpayers money, that we
Yes.
might be able to use that money in other ways with providers who might need it in different, with NASP or other, DD providers such as them. So,
I agree. It might be that coming to this committee to say, why don't you expand your budget? Unless you have veto protection, it's not going to happen. But what are the other opportunities, as you said, maybe to improve care and the quality of care under an umbrella of healthcare delivery models? And that's why we're thrilled that you're looking at this, is how can we do this? Maybe without expanding resources, we're glad if you could do that, but how could we set up models, methodologies that could meet those things?
well, this seems like a very simple problem to fix, so it shouldn't take too much.
Yes,
I was being facetious.
thank you.
Okay, all right. Any other questions from the committee? Thank you very much. Appreciate it. All right, and then we'll have Ashley Brown with CAPCON.
Good morning. Thank you. Thank you, Chairman Hansen and members of the Health and Human Services Committee. My name is Ashley Brown, ASHLEY, BROWN, and I am the president for KBC Nebraska, a private nonprofit organization that provides a variety of programs and services to Nebraskans. And I also serve as, and I'm here today, as the president of the Children and Family Coalition of Nebraska, otherwise known as CAPCON. CAPCON is a nonprofit service provider association comprised of 11 licensed and accredited organizations that provide an array of critical services to individuals, youth, and families in all 93 counties of our state. Excuse me. Members include, but are not limited, member services include, but are not limited to the continuum specifically of child welfare services under the contract with the Department of Health and Human Services. These services are such as foster care, home studies, emergency shelter care, adoption, kinship and parenting support and education, intensive family preservation, reunification, group home, and residential services. So my focus today is really specific to the child welfare piece of things. The rates for reimbursement across these specific services are determined by DHHS, and the rate methodology is unknown. A structured rate assessment has not been completed for child welfare services in Nebraska since before lead agency contracts in 2009. In response to lead agency contracts and having among the lowest foster care reimbursement rates in the nation, the legislature created the Nebraska Children's Commission and the Foster Care Rate Reimbursement Committee to recommend rates very specific to foster care providers, so foster parents and those agencies in 2013. This has been a helpful formal process conducted every 4 years. However, it's only structured to address one type of service in the child welfare continuum, again, specifically foster care. Historically, the rate adjustments for foster care have kept pace in Nebraska since 2014. However, this was only accomplished through legislation and routine, and an established routine and formal process. It's critical that a regular and consistent process be established to ensure rates for all services are evaluated and adjusted. There's no such process currently, which leads providers having to focus significant resources that are already scarce, we've heard that, across the services, towards education and advocacy to try and sustain quality services for those in need. We recommend any methodology developed account for the cost of general operating expenses, to include inflation, regulatory and licensing compliant, staff credentialing, staff training requirements, the requirement of evidence-based practices across the continuum of child welfare services in urban, rural, and frontier areas of our state, We would recommend the legislature and DHHS conduct a rate assessment to rebase child welfare service contracts. Was conversing with some of my friends, and at least in my time, there's never been a rebase for child welfare. And so we'd ask that happen. In 2022, LB 1173, Child Welfare Transformation Work Group Finance Model, outlined some key strategies for developing adequate finance strategies. Many of CAFCON's members participated in this work and absolutely remain committed. It just has kind of disappeared. So to close, please know that we truly appreciate the work the committee has done over the years. Even so, with no structured or predictable way to evaluate and adjust child welfare service rates, providers are continuously at a disadvantage in terms of planning workforce needs, hiring employees, and training and retaining them. For this reason, we continue to ask for your support in establishing a formal structured rate evaluation and methodology.
Thank you.
You're welcome.
Any questions from the committee? Senator Reapy.
Thank you, Chairman. I have two specific questions. One, in your, I guess it's your second paragraph, you talk about being licensed and accredited. Are those redundant, or does that mean some are licensed and some are accredited?
The answer to that would be both. So you can, I work for KBC Nebraska. We are licensed and accredited.
Is that redundant though?
No, we're licensed with the state of Nebraska. We're accredited by the Joint Commission.
I see. I'm always looking for excessive regulations and unfunded mandates.
I'd like to look for those and eliminate where we can also.
Okay, the second question that I had is, I think it's in the third paragraph, last line, it says, and I quote, historically, the rate adjustment for foster care have kept pace in Nebraska since 2014. However, this was only accomplished through legislation that established a routine formal process. Is that now, did you say that later? I was trying to read and listen.
That's okay.
Has that disappeared?
The Children's Commission exists and the Rate Reimbursement Committee exists. So those things do continue. I think the point being made there is that progress was made only through legislation, but specifically for foster care rates, not for rates to avoid foster care altogether, not for rates to reunify families timely, those types of things.
Seems to me like we've had a long-standing, maybe an 8-year problem with staffing in foster care of social workers. Is that still an issue?
It's absolutely true. So really the same goes that many of the previous testifiers have spoke to. So very specific in child welfare, this is really hard work. I'm a social worker. I've done the work. People doing this work bear witness to really hard things. Community-based work is hard. And oftentimes involuntary service provision is hard. So people aren't coming to us. My sweet vision of the world is that we have a child welfare system where people go and ask for help. We tell them they need help. And so that in and of itself becomes really difficult for a professional, looking to be a helper. On the community-based fashion of it, we're going into communities, we're going into homes, we're doing it we're doing it in the evening, we're doing it on the weekend, we're doing it in the middle of the night when there's a crisis. So much like I think Alana with NASP had spoke, it's really hard work, and people looking at child welfare could also go to Menards and make more money.
Thank you, Ms. Jones.
Senator Walls.
Thanks. You mentioned the LB 1173 from 2022. Do you recall, was there a timeline where that would, like they were saying, by this time, we would like to have the results or the conclusion on what you came up with regarding adequate finance strategies? Was there any type of a timeline?
So Senator Walls, I'm gonna preface, I know this is on the record, but don't hold me to. There was some reporting timelines, I think, for DHHS to report back to the legislature. But from there, it's not my recollection, but I'm happy to kind of get some details on that. What I would say is I think that a lot of really good work went into, there was a lot of collaborative work happening, and with administration changes within the Department of Health and Human Services, both at the CEO level and the Division of Children and Families. I'm telling you, I was hearing 1173 in almost every conversation I was having, and I haven't heard it for over a year. So it's kind of like it happened and then we don't know what happened. So
Can I ask you one? Was DHHS involved in those conversations or in, okay.
yeah,
so we're-
totally. They were generally the sort of facilitator of it, bringing providers together. So there was some hopefulness, I think, in terms of what could be.
Yeah.
So.
Same thing.
So the foster care reimbursement rate committee, you view that as a good thing?
Yes.
And that has been, like you said, a little more of a formal process about how to maybe look at rate methodology, in particular just foster care, right?
Absolutely. Yes.
So it almost seems like that's kind of an approach we're trying to take here, but more on a broad scale, I guess. I know
Absolutely.
each, I would say industry, but each area is kind of individualistic, right? So I
Sure.
know we can't just say everyone follows this one thing, whereas, as the people have mentioned before, there's different regulations that so others have to follow. And
You bet.
Federal government, Medicaid involved, and I know that's all different with everybody else, but I think that's kind of approach we're almost trying to take broadly throughout the provider rate system, I guess, in a way, right?
Yeah.
Whether it's kind of creating a committee and trying to figure it out, so people have some kind of foresight on what's going to happen with provider rates. So that's good. It's good to hear that at least in some way that has worked well with the foster care.
Absolutely. And that's a really diverse group of individuals that comes together. That's not just the state or just, it's a diverse group of people who are coming together, and really collaborating. And I would say that, yes, and the organization, KVC, who I work for, we're a DD provider, we're a mental health organization, we're a child welfare. So we live in all those spaces. And so it is easy. It's not easy to paint with a broad brush to say, here it is generally. But I think to put some structure to it, very specifically with child welfare, we're singing for our dinner every year. And there's no rhyme or reason to kind of what's picked. We've made some good progress. You'll hear from Ryan Stanton at some point today, and we've made some good progress in some areas, but also kind of misuse of dollars. The most recent rate increases were done through ARPA and were initially told to us to be temporary. Now they are sitting in the proposed budget to stay the same, but there's no increase.
Missouri does a cost of living adjustment, I believe.
I think they do too. So I will tell you, as I was sitting here, so KVC operates in several states across the nation, Missouri. I've done a reach out to my colleague, the president of KVC Missouri, to kind of dig in and understand. If I learn anything interesting, I'm happy to pass that on to you or Bryson.
Okay, thank you. One of the questions I did have in here, do child welfare providers use the prospective payment cost model for CCBHCs?
No.
I thought that was something that Senator Wishart passed, LB 276. Okay. And how many child welfare providers are Medicaid?
Oh, gosh. I would be making a guess. A decent number. I think in order for organizations to sort of make it, you got to be diverse in and also that idea of just kind of a, holistic approach to serving individuals and families. But I would be taking a complete guess at
Okay,
that.
that's fine. Just kind of curious.
Sure.
Okay, any other questions from the committee? Seeing none.
Thank
very
you.
much. All right, Nick Giuliano with Rates.
Good morning. Senator Hansen, members of the Health and Human Services Committee. My name is Nick Giuliano, Nickjuliano, and I'm President and CEO of Radius. And I appreciate the opportunity today to testify on LR 392. A little bit about Radius, and you have a handout in your packet. Our evidence-based program at Radius opened in July 2023 and is composed of 4 services: residential, school, in-home, and a unique partnership with Charles Drew Health Center to provide physical and behavioral health care on our campus. We currently serve justice-involved youth, ages 12 to 18 and their families on our campus in Omaha, which is designed to keep kids on juvenile probation in the community, near their families and support networks while they receive treatment. As it relates to rates, Radius currently receives reimbursement for 3 services: We have a rate for our residential program and our in-home family services. That rate is paid by the Administrative Office of Courts and Probation. And we also receive an education rate as we operate a Rule 18 school. And those funds are administered by Health and Human Services. Of these three rates, only the education reimbursement has a cost basis. So 2/3 of the rates we receive are set, as mentioned by a prior testifier. We are price takers. And while with a new service category like we have with Radius, there was an opportunity to negotiate. That's not on a cost basis. But Radius is not unique in the provider ecosystem. And over the course of my 29-year career in nonprofits, I've seen the impact of stagnant provider rates across our state. And what we know is that impacts capacity, as has been mentioned this morning. And I think the Radius story really illustrates the capacity issue, because we were created to address a need. There's a gap in services. There's a capacity need in Omaha to serve a population of young people who were being sent to Arizona, Utah, Wyoming, Ohio to receive services, because there wasn't a viable, suitable program in the Omaha area for the young people that we serve. But Radius only exists due to the generosity of the philanthropic community. Current rates do not support expanding existing services for any nonprofit, nor does it support creating innovative services as needs change. So capacity is ultimately tied to access. So our current rate environment is preventing those in need from accessing services in communities across Nebraska. Ashley did an excellent job of laying out prior efforts to look at rate studies and methodologies. I would add one that was done in 2008. Some of you are familiar with the Simon Johnson rate study, which was commissioned by a group of behavioral health providers. That would be another excellent methodology to look at, particularly because they accounted for all of the factors Ashley mentioned, plus inflation, consumer price index, medical expense index. Each of the studies mentioned have merit, and we would really suggest a thorough review of those existing studies, even if they're dated. You know, the Simon Johnson study is now 16 years old, but the methodology is sound and still relevant to what we're talking about today. And the last piece is in looking at any new rate methodology, it's very important to include all the factors that Ashley mentioned, including a mechanism for an annual review and adjustments based on the cost drivers. A program like Radius, which recovers 70% of its costs, requires me to go out and find 30% to make ourselves whole. So next year on a $7 million budget, I have to raise $2 million to keep employees and keep the lights on and keep the services there. And so this is very important. Insurance was mentioned. Now we're only an 18-month-old organization, but my insurance nearly doubled last year. I had no claims. We're a high-risk organization because kids live with us. That's completely out of our control. Also required by licensing and regulation. So I think the methodology approach, if we're going to move forward with this, which we would support, needs to take in all of those factors that impact all businesses. Nonprofits have most of the same cost drivers as regular businesses. So thank you for this opportunity, Senator Hansen. Thank you for looking at this important issue, and I'm glad to take any questions at this time.
Thank you. Senator Reapy.
Thank you, Chairman. Do you participate or get any funds from United Way or CHAD? Either one of those two, which are both, United Way of the Midlands and CHAD are both based in Omaha.
Yes, not currently. We've applied for United Way funds and have not yet been successful, but we'll plan to continue to.
Is this your first year in applying, or have you repeatedly applied?
I think we've had 2 opportunities at grants.
Okay. So it's not like you've been after it for 10 years and been rejected.
Right.
Okay.
Right.
Fair enough. Thank you for being here. Thank you, Chairman.
You mentioned a couple other states. Do you know if any other states incorporate like a public-private partnership when it comes to kind of what you do and
Yeah.
anywhere else in general, like if the public donates a certain amount, is there an incentive from the state to match that or?
Senator, that is a great question. Some of you I interacted with when I was previously at Boys Town as an advocacy public policy role, and I was more knowledgeable of other states at that time. That has been a few years, so I'm not as up to speed. I do know when we're looking at other states that I think looking at states that have an urban concentration and a large rural geography be very important. As we look at the cost drivers and the contrast between urban and rural areas. And obviously, Nebraska is a state of generosity. Omaha is a state of great generosity with philanthropic support. So that public-private partnership is going on here across our state, and it's certainly happening in Nebraska. I'm not up to speed anymore on what's going on regionally or nationally, unfortunately.
Yeah, just curious. And I don't know if you mentioned this, but it's one of the things I have in my notes. It costs about $400 a day for one youth. Is that about right?
So our current rate for residential is $352 a day. We're finishing our first full operating year. So I will calculate my cost of care and have an exact number, but I'm sure that cost per day will be north of $400.
Okay.
And until you've had a full operational cycle, it's hard to do a real accurate accounting for those costs, but that's a pretty good estimate of where we'll land. Just for the residential piece, that does not include the work that we do with families while their children live with us, or the education piece, which is funded separately.
Okay. Any other questions from the committee? Seeing none. Thank you for coming. Appreciate
Thanks.
it. All right. Next, we got Ryan Stanton with Compass and Nebraska Alliance of Family and Children's Service Providers.
Good morning. Thank you. Thanks so much for having me. My name is Ryan Stanton. That's spelled RyanStanton. I'm the CEO of Compass, who's a family service provider in Kearney. I'm also the president of the Nebraska Alliance of Family and Child Service Providers. We are an association of child welfare providers who individually contract with DHHS. We drive over 3 million miles to provide child welfare services to over 2,000 families all across Nebraska each year. I want to thank you, Senator Hansen, for introducing LR 392. We truly appreciate you focusing attention on provider rates and the methodology, or lack thereof, in which they are established. As the committee knows, the Children's Commission periodically reviews the reimbursement rates specifically for foster care services, like Ashley mentioned, and recommends increases that legislature typically adopts. Therefore, I'm not going to focus my remarks on that service. Instead, I want to focus on the other child welfare services that includes parenting time, supervised visitation, family support, drive time, IFP, and IFR. I've provided a handout that defines those services and gives a history of rate increases going back to 2010. As you can see, for 10 years, those services did not receive any rate increase. Over the last 5 or 6 years, these services have received a small or temporary rate increase, most recently in 2023 when ARPA dollars were directed to supplement rates for those services for the 2 fiscal years beginning July 1st of 2023. ARPA dollars brought about time, but not a solution. The last independent rate study that we are aware of with child welfare services was done in 1996. Over the last 7 or 8 years, DHHS leadership has talked about doing another one. However, it has not come to fruition. And unfortunately, we don't have the luxury of time to do one now before ARPA funding runs out. Therefore, at the request of DHHS leadership twice over the last 4 years, providers have individually provided them with data that speaks to the actual cost to provide these services. We most recently did this in June in order to help DHHS prepare a budget to give to the governor. We've also worked with Senator Conrad to introduce LB 510 a couple of years ago. That would require an annual cost of living adjustment being made to provider rates, and that bill died in committee. We've also had conversations with the Children's Commission regarding the feasibility of them reviewing rates and making recommendations for other services other than foster care. However, that would require additional funding for them, but in my opinion, it's an option worth pursuing that's more quick in nature. It is important to note that while I'm talking about regularly increasing the rate for specific services, these services are largely preventative in nature or designed to reunite families in a timely manner. This is another way of saying they are cost effective. Placing a kid in foster care is the most expensive solution, and having them stay there unnecessarily can cost the state untold dollars, in addition to being very traumatic for the child. So I'll just stop there and answer any questions you might have.
Thank you. Are there any questions from the committee? Senator Day.
Thank you, Chairman Hansen, and thank you for being here today. I appreciate how you have given us a timeline of recent years and sort of connected it to where the money is coming from in terms of provider rate increases. So in this graph here, you show us specifically July 1st, 2025 through June 30th, 2026. It says it would be detrimental to the child welfare system to return to 2022 rates.
Yes.
I mentioned earlier the upcoming year and potential budget cuts. Have you looked at that? And does that include, what would your rates look like?
Sure. So right now, as I mentioned in my testimony, twice in the last 4 years, we've given data, like specific
Right.
data. I think 25 organizations provided data by June to DHHS, the Children and Family Services specifically, so that way they could go to the governor.
Right.
So CFO John Meals, as well as another person with Child and Family Services, said that they requested a $10 million budget increase for provider rates, but that is to keep the rates the same they are, to basically, because the ARPA rates were just
Okay.
temporary.
Sure.
And so July 1st, 2025, depending on what the next biennium budget comes, depends on what that rate will be. If it doesn't include those rate increases, then effectively our rates would go down back to where they were in 2022.
Back to 2022.
Mhm.
So if the $10 million increase is not included in the upcoming budget, your rates will go back to 2022 rates.
Correct.
Okay, thank you.
Senator Eby.
Thank you, Chairman. I'm looking at this, and I assume that you may also be the chief financial officer and the chief fundraiser.
Yes, I fulfill all those roles, yes.
Yeah, okay. And it looks here that it's a high reliance on ARPA funds, which are, as you said, not going to be here.
Right.
Okay. I just want to, in my mind, confirm that. Thank you, Chairman.
You kind of took my question there too, so. And I think I had questions, but you answered most of them in your handout here. So
Okay.
about establishing a long-term, predictable, sustainable method of determining provider rates that mandates accountability for both providers and DHHS and does not require annual biannual legislative approval.
Can I just mention one additional thing?
Yeah.
So Ashley had brought up LB 1173, and that, the timelines was a report due to this committee, I believe, was the only timelines that we've been made aware of. And ever since then, there's just not been a lot of talk about it. So in the LB 1173, they produced a practice model report as well as a finance model report. I do know that in that finance model report that they gave, they had referenced several states, and I think Indiana was one specifically that they took a deep dive in. And I think that Ohio may have been the other one. I can't remember. It's been a while since I've reviewed the report myself. But I know that they looked at several states specifically and have some specific data in that report that you could potentially reference when looking at other states as well.
Yeah, that came out in December of 2022.
Yeah.
Yeah.
Do you have a question?
No, I kind of have a question, I guess.
Senator Walls.
Thank you, Chairman Hansen. It looks like I was looking at the bill, it looks like that group terminated or was set to terminate in December of 2023, I think. The work group and strategic leadership group shall terminate on December 31st, 2023.
Yep.
So my question is now, since it just seems like a lot of good work went into this,
Yeah.
a lot of good stuff went into this, and then, you know, it was only a couple years ago, and we've already forgotten about this report. So I guess my question is there any way to maybe bring this back and use the information that was so thoughtfully considered in this report? Have you heard of anything, I guess? Of
So,
anything that's come out of this?
We recently, actually Monday, we did have a statewide provider meeting, and that was led by the DHHS leadership. So Director Bish is back from maternity leave, as well as some deputy directors were on that call as well. There was a specific question asked, like, what about LB 1173? The response from DHHS was, well, it gave us some recommendations, but that we were already kind of pursuing, specific to drawing down more federal dollars. So Title 4E, Title 4B, TANF dollars, those types of things, where they apparently, even before the termination of the LB 1173 work group, they were already implementing some of those things to be able to draw down. I had a conversation with CEO Corsi, who said that in his opinion, they've made significant progress in that area. I haven't seen any specific numbers brought out, but in general, they stated that. So I know that was one of the recommendations, because Nebraska has historically been super low in drawing down those federal dollars and relying more resources in the state general budget. And so I know that that's been an effort that they've been trying to do. But other than that, I think we regularly meet between providers and DHHS, and I think Ashley would agree that, that we would be happy to, review the report, review the recommendations, and see what other things that we could potentially do to partner together to make progress for the state in child welfare.
Yeah, that'd be great. Thank you.
I think it's an indication I've also got from DHHS is their inclination to kind of look at drawing down federal funds more and seeing how we can be more efficient in that area. So I think that's kind of what you mentioned there.
Yeah.
Which would be great.
Yeah.
All right, seeing no other questions from the committee. Thank you very much.
Thank you.
All right. Jeremy Starkle with Right to Home and Nebraska Home Care.
We're not going to be able to. You can't keep putting solutions out there and then simultaneously like.
All right.
Welcome.
Good morning, Senator Hansen and fellow members of the committee. My name is Jeremy Starkle. I am the co-owner of Right at Home franchises in Norfolk, Columbus, Grand Island, Kearney, and Fremont. We operate a private duty home care locations throughout rural Northeast and Central Nebraska. Our primary goal is to ensure that seniors and disabled adults receive the care they need to remain in their home. Nebraska's in-home personal care companies support activities of daily living. These services include bathing, dressing, grooming, transferring clients, medication reminders, toileting, light housekeeping, errand services, essential shopping, food prep, and laundry. I'm also a board member of the Nebraska Home Care Association. Our association represents Nebraska's personal care companies and home health care companies. Our association believes that a permanent rebasing methodology is needed. Today, I am speaking on behalf of our members to request a comprehensive review and rebalancing of reimbursement rates for Medicaid age and disabled waiver services provided to Nebraskans by personal care home care companies. For the Medicaid age and disabled waiver program, Nebraska DHHS negotiates a rate with each agency provider separately based on the provider's estimate of their costs for paying caregivers, aides, administration fees, supplies, and technology. DHHS reviews each provider's estimated costs and negotiates a unique rate for each one. There are Medicaid age and disabled waiver providers that have been negotiating with the state for a number of years, and they are being reimbursed less than newer providers. There's a difference in bill rates in upwards of $15 to $22 an hour being paid to Nebraska agency providers. For example, our rate is at $32 an hour. However, there's an agency in our same service area that's at $48.60 an hour that provides the same services. This creates an uneven advantage in favor of new agencies that can pay much more over agencies that have been in business for several years and have built a solid reputation in the caregiving community. We have had numerous conversations with DHHS regarding the need for standardized rate, in which they are supportive. Recently, the department engaged a consultant to conduct an aged and disabled waiver rate study, which supports the need to develop a new rate model based on many of the factors we have recommended. A copy of that study is in your packet. If you go to page number 7, you can see what CBiz Optimus actually recommended for a standardized rate for personal care for agencies of $43.63 an hour. Our association supports a fair and equitable system that allows Medicaid waiver providers to receive reimbursements that cover actual costs of care and service delivery, including ability to offer competitive wages and benefits for employees and caregivers, reimbursement that covers the cost of mileage for home care visits, the reimbursement of overhead and operating expenses. We support an increase in rates that will be a sustainable model. Also, any permanent rebasing methodology that the committee develops should consider the difference in cost of delivering care in urban and rural areas of Nebraska, which would include items such as travel time and mileage to serve rural patients. We also think that the methodology should require rebasing provider rates on a regular interval, so changes in factors like inflation, cost of doing business, and competitive wages can regularly be considered. Other states have successfully employed such a needed tool, and it would benefit Nebraskans. We would support a review and rate adjustment every 1 to 2 years, and just to keep pace with increases in care delivery costs. So we definitely appreciate your time today to learn more about the reasons why a standardized rate needs to be established for Medicaid aged and disabled waiver home care services for Nebraskans.
Thank you. Any questions from the committee? Senator Reapy.
Thank you, Chairman. I have a question in regards to $32 an hour
Yes.
versus the newer agency that I believe gets 48.60, 40. Is that based on an acuity? I mean, do you have, on clients that you would have, do they do an acuity type of payment?
They don't. It's just based on, from my understanding, DHHS really just kind of negotiates between provider to provider what their standardized rate is going to be. And it doesn't depend on acuity. So it doesn't depend on what the scope of services actually is.
So you'd have every incentive to take the least care requiring patients.
Right, 100%.
Okay. Okay. That's all I have right now, Chairman. Thank you.
Okay.
Thank you.
I think you brought up a point I think a lot of other people brought was, I think we have to be somewhat cognizant of the fact of what our surrounding states are doing when it comes to what they're paying their employees.
Right.
And why that might make it kind of difficult for us to retain employees.
Sure.
Like that's another common theme that we're hearing is the inability to kind of keep people in the workforce. When it comes to just pay, but also be competitive to other states. So there's not going to Iowa, South Dakota.
Correct, yeah.
So you're not reimbursed for mileage?
We're not. We actually do pay mileage for when we do transport clients, but we basically eat that cost as a provider because we understand that if the caregiver is going to use their own vehicle and provide that wear and tear and also gas mileage or the gas that they're going to use to transport that client, that we actually just reimburse them at the standard IRS reimbursement rate.
So again, the question I've been asking a lot of people, so a common rate methodology would be a good thing for you?
Yeah, absolutely. It would definitely be a great thing for us. I know that there's so many different rates out there. And for instance, it's difficult because a lot of times if we have a caregiver that's been with us for 2 years
and they jump ship to an agency that's going to provide, pay them an extra $5 an hour because they have a higher reimbursement rate. A lot of times the clients build those relationships with those caregivers, and they'll go with that caregiver to the other agency. And so, that also affects our business because of that. So really, if those agencies are getting those higher reimbursement rates, we're at an unfair competitive advantage as well.
And you're primarily funded through Medicaid, correct?
Yep, primarily through Medicaid. We do accept some private pay. And then we also work with the VA to help veterans and their spouses. That also covers our services.
Okay.
But primarily Medicaid.
Senator Reapy?
Thank you, Jim. A quick question.
Yeah.
Do you keep a quote unquote medical record on all your patients?
We do, absolutely, yeah.
Okay, that's all I want to know. Thank you.
Yep.
Thank you.
Any other questions from the committee? Seeing none, thank you very much.
All right, thank you. Thank you for your time.
All right, and next, Tanya Jensen Nelson, Pediatric Home Services, Craig Home Care, and Nebraska Home Care. And just for the committee, we're on testifier number 10 of 14. So, welcome.
Hi, everybody. My name's Tana Jensen Nelson, TANNAJENSEN-NELSON. I am with Pediatric Home Service, previously Craig Home Care. I am the branch administrator for the Omaha branch, and I'm a member of the Nebraska Home Care Association. Our association represents Nebraskans' personal home care companies and home health agencies. Thank you for introducing this interim study, and thank you for the opportunity to share the information with the committee on this topic. Our association believes that a permanent rebasing method is needed. Today, I'm speaking on behalf of our members to request a comprehensive review and rebalancing of reimbursement rates for skilled nursing, private duty nursing, and therapy services provided to Nebraskans by home health agencies under the Medicaid Managed Care Program. The reimbursement rates for these services are published on the Medicaid Home Health and Private Duty Nursing Fee Schedule, which is one of your handouts. A comprehensive review on these rates has not been conducted in at least the last 20 years. We've seen home health agencies close in our state over the past few years, with 2 for sure closing by the end of this year. Other agencies have stopped serving Medicaid beneficiaries, or they've significantly reduced the number of Medicaid patient referrals that they accept due to those low reimbursement rates. In your packet is also the Medicaid fill rate study indicating that reimbursement is the top reason why patients are being turned away. And also in your packet is a map of Nebraska's home health agencies. And you'll see that some counties have only one agency, and they only serve about a 30-mile radius, so they don't even cover the entire county. Our home health agencies serve children through the elderly. There are children who are in facilities wanting to get home, but there's no home agencies that are available to staff them to care for them. This is directly tied to low reimbursement. We ask that the legislature look at neighboring states and their reimbursement rates for school nurses, which is higher than what nurses are paid to deliver critical care to patients with complex care needs, such as trachs and vents in their homes. A blended rate for RNs and LPNs working in home health care is another option to consider. Home health agencies are also turning away referrals for our elderly patients because of low reimbursement and lack of staffing. We believe that developing a home health rate model to address skilled nursing, private duty nursing, and therapy services is a more prudent and data-driven method for addressing the challenges with access to home health care. A 1 to 2 year review of the rates needs to occur to help keep pace with increases in home health delivery costs. In your packet is an analysis by an industry partner that has conducted reimbursement rate studies for home health cares in other states. The handout references the increase in Nebraska home health discipline cost per visit from 2020 to 2021 based on the CMS cost report data. The numbers certainly would have changed since that time, as this does not account for the cost of inflation or the rising cost of fuel for nurses that have to drive to patients' homes. 2 years ago, an informal cost report review was conducted looking at a cross-section of Nebraska home health agencies representing rural and urban areas. That review identified Medicaid, home health, skilled nursing, and private duty nursing as the areas with the largest gaps in reimbursement rates as compared to actual care delivery costs. Since that time, home health agencies have requested that occupational therapy, physical therapy, and speech therapy rates be adjusted as well. Often when Medicare and Medicaid rates are determined, they're not based on the true cost of care. That's because the true cost of providing home health care cannot be calculated solely through publicly reported cost reports. Instead, outlier overhead items such as sign-on bonuses and tuition reimbursements that can only be collected through a survey process must be considered when calculating the total cost to deliver services in the home. In many cases, this survey process does not happen, resulting in severe underpayments. And you changed the light on me and I lost where I was at. You scared me.
The plan is working.
I guess. When reimbursement rates do not keep pace with operating expenses, it means that home health agencies are unable to hire and retain adequate number of nurses, therapists, aides, and other staff to meet the needs for patient care. We would recommend having our industry partner put together data for you that will help determine the true cost of care for home health providers in Nebraska, including not only review of the public reported costs, but also the outlier overhead such as those sign-on bonuses and tuition reimbursement. Addressing the home health reimbursement rates will also support Nebraska's hospital in reducing the number of rehospitalizations and reduce the state's overall cost from that. It will also support residents in our state's skilled nursing and assisted living facilities who benefit from home health care services as well. I appreciate your time, and our committee appreciates your time to learn about the reasons why a permanent reimbursement methodology is needed for Medicaid home health, skilled nursing, private duty nursing, and therapy service for Nebraskans.
Thank you. Are there any questions from the committee? Senator Reapy.
Thank you, Chairman. Maybe you can help me out on this, but my recollection is that there was a state law that required agency reviews every 2 years. And it was in the year prior to when the budget was put together, which from a timing standpoint, you're young, maybe that was before, somewhere or another, somebody tell me I'm not totally crazy. Is there a statute out there that says that there has to be a mandatory 2-year review every 2 years of rates?
Yeah.
I don't know. I'll have my staff
I
go
thought
back and take a look.
there was some regulatory requirement that we do statutory.
I'm sorry.
I thought there was some kind of regulatory requirement that we do that.
Yeah, I thought so too.
I have to look and see. Bryce will look at it.
That'd be interesting because if it's still on the books, maybe we've just ignored it. And so we may have some foundation there to go after. I don't know. Yes,
Well, CMS requires it every 5 years.
maybe that's it. Oh, maybe every 5 years?
CMS does.
Requires that states review their rate setting methodologies at least every 5 years.
Boy, that's, in this business, that's a long time.
Yeah.
You were asking about a state requirement.
I thought there was a state requirement, but that may have been a dream. I know. Maybe we can check that out.
I'm looking in the eye. You guys know.
I was looking at my people too. So I need a yes or no.
Any other questions from the committee? Seeing none, thank you very much. All right. Katie Bass with first 5. We got 3 more test runs after this. Welcome.
Hello, Chairman Hansen and members of the Health and Human Services Committee. My name is Dr. Katie Bass, K-A-T-I-E-B-A-S-S, and I am the Policy Research Manager representing First 5 Nebraska, a statewide public policy organization focused on supporting policies that promote quality early care and learning experiences for young children. Thank you, Chairman Hansen, for the opportunity to discuss child care subsidy reimbursement rate setting. Now, in Nebraska, subsidy rate setting must meet the requirements of the Child Care Development Fund, which is the federal funding source for subsidies, or CCDF, and Nebraska state statute. The requirements dictate both the frequency, the acceptable methodologies for determining rates, and the minimum rates. So subsidy rates in Nebraska are updated on July 1st of every odd numbered year, and that is directed in statute 43-536. You may remember that last session, the legislature passed LB 904, which updated that statute to better align with those CCDF requirements around what methodologies are acceptable for setting rates. So now the statute does require that we assess both the market rates or the price of childcare and we assess the cost. Previously, there was no condition around assessing costs. States do have a lot of discretion from CCDF on how they set their rates. But they do have to use either a statistically valid and reliable market rate survey or a pre-approved alternative methodology like the cost estimation model that Senator Reapy was mentioning earlier, or conducting a cost analysis. States are required to conduct that cost analysis, but they are not necessarily required to incorporate that into their rates. And we stopped short of making that requirement on how that has to be incorporated into rates with that statutory change last year, just that the assessment has to happen. To date, Nebraska has never reimbursed childcare providers based on their costs. They've relied on a market rate survey to determine those subsidy reimbursement rates, and that is a survey of childcare prices with no specific information on the cost of providing care. I am going to skip over my section I have here on the childcare cost model because it has already been mentioned, and you all have heard me talk about that in almost every session for the last 2 years. So I'm going to give you a quick break. But I do want to highlight that there is not one reimbursement rate for childcare subsidy providers, which is why I've included the rate sheet that is offered by the Department of Health and Human Services in my testimony today. So there are actually 137 different base rates for childcare in Nebraska, and that's based on the age of the child, the setting, their rating, their quality rating or accreditation, and how often the child attends, whether it's for part of the day or the whole day. And then if you add enhancements into that, that number jumps to 409. So it's not a single reimbursement rate. I see I have my red light, so can I make one more quick point? That we do also have in statute that a childcare provider cannot be subsidized at a rate higher than what they charge their private pay clients. So that means for any childcare provider whose rate might be lower than the rate offered, the department does have to create an individualized reimbursement rate for that provider. So you can imagine that that is quite a bit of administrative time and effort to find what all of those rates are. And with that, I will stop and I will try my best to answer any questions you might have.
Thank you. Are there any questions from the committee? Very good.
Short answer.
You cited some statute.
Yes, I have 2 different statutes for you.
Is that in your letter here?
They are both listed in the letter.
Swell. I'll dig it out.
All right.
Okay. Thank you. Thank you, Chairman.
So again, a kind of rate methodology formula, would that be appropriate for what, for who you represent and childcare in general?
This is a little bit difficult for me to answer because we're not necessarily a Medicaid reimbursed, right? We're in a different area. And so I would struggle to know how those methodologies work in that system and whether or not they would meet the federal requirements around childcare subsidy, right? So there already are requirements about a methodology that we do have in statute. So I don't know how well those would adapt with anything that is funded by Medicaid.
Okay. And how are rates determined for subsidy providers?
Sure. So right now it's based on the prices. It's a market rate study that happens every 2 years, right? So typically that data is gathered based on the price of care in the even numbered year, then it's analyzed. The prices are then ranked based on all of those different categories I mentioned, like age of child, right? And then they set it based on the statutory change we had recently. It's the minimum rate is the 75th percentile. And before that, it was between the 60th and 75th. So it's a pretty complicated methodology that does set that rate, but it's based off price.
And DHS partners with Buffett Early Childhood, right? Don't they?
Buffett Early Childhood Institute has had the contract to conduct that market rate study.
Okay.
This will be the first one that will include a cost analysis, right? This upcoming one for 2025. So we'll be watching to see how that is incorporated.
Okay. And so like we've mentioned before, are there like other incentives? What incentives are there for childcare subsidy providers?
An incentive-based
Is
system.
like a quality
Yes.
care?
We do have a quality rating improvement system in Nebraska, right? And so if you are in that quality rating improvement system, which has 5 different levels, 1 through 5, at step 3, you get a 5% increase in your reimbursement rate. That is also true if you are accredited through a national accrediting organization. You get a 5% increase. And then there's an additional 5% if you reach step 4, and an additional 5% to when you reach step 5. One of the questions that we have been fielding a lot is whether or not that increase covers the cost of improving your quality to that level, right? Which is why we have been kind of talking about that cost estimation model, because that's what's supposed to help you model that out to see if it does.
Okay. And just from more of a, from your perspective, how has inflation affected early childhood care?
It's been a major issue for our providers. I mean, I think between just the general costs of food and goods, and certainly the costs for employees, as you've heard over and over again, is staffing. This is one of the interesting things, I think, when you look at the way rates are structured in Nebraska. We have a difference between rural and urban that's quite significant. I'm not convinced that the costs between rural and urban are so significant, right? That would justify that gap in reimbursement rates. And that is largely based on the fact that the cost of your supplies is not that different. In a way, the cost of your wages are not that different in a way that they perhaps historically had been when that division was originally kind of built in.
Okay. Thank you. Senator Day.
Thank you. I just want to clarify, you mentioned statute 43536.
Yes.
And does that apply only to providers who are providing under the child care subsidy, or is that for all providers?
That is only for providers that are, well, wait, let me ask the question. Let me rephrase your question here. Are you asking whether participation in the market rate survey or
So
what
it just
their
says
rates are?
in terms of updating rates every odd numbered year as outlined in the statute. Does that statute apply to all providers, meaning we should be updating rates for all providers every odd numbered year, or does this only apply for child care subsidy?
Only for child care
Okay.
subsidy.
Thank you.
And I think Senator Boers LB 904 then allowed a little more flexibility, didn't it? With instead of
Yes.
going completely market rate, then you could use other kind of.
Exactly.
indicators.
You could use one of the pre-approved methodologies or combine it with the market rate study. But we did, just say that gives more flexibility. It didn't necessarily dictate how that would happen.
Okay. Any other questions from the committee? Seeing that, thank you very much.
Thank you.
All right, Nick Weber, Creighton University, Nebraska Physical Therapy Association. Welcome.
Good morning. I'll be brief. Chairman Hansen and members of the Health and Human Services Committee, my name is Nick Weber. That's Nickweber. I'm a physical therapist and currently serve as president of the Nebraska chapter of the American Physical Therapy Association. I'm here to represent our membership and speak as one of over 3,300 physical therapists and physical therapist assistants in Nebraska that are licensed by the Board of Physical Therapy to serve our respective communities. Physical therapists are healthcare professionals with expertise in movement analysis and work to restore function and movement for people with many conditions, including those that affect muscles, bones, joints, and nerves. And like other medical billing practices, physical therapy billing relies on matching services rendered with standardized codes that let insurers and other parties know exactly what treatments a patient received. Our services rendered to Heritage Health members are reimbursed based on the Medicaid fee schedule, which is why this is a topic of interest to our members. When rate increases don't keep up with practice expenses, it impedes our ability to deliver evidence-based, medically appropriate care. And when no rate increase is given, as has been the case 3 times over the past 8 years, it affects our ability to pay rent for clinic space, maintain a qualified staff, afford practice expenses like electronic health records, technology for telehealth services, and that ultimately jeopardizes patient access. To demonstrate that point, I'd like to draw your attention to an alarming trend following the rate freezes to the Nebraska Medicaid fee schedule in 2018 and 2019. Utilizing the data provided by DHHS's Division of Medicaid and Long-Term Care in their annual reports, you can see on the graphics in front of you that since 2019, the number of practices accepting Heritage Health members for physical therapy services has decreased by 40%. And the number of physical therapy providers in network has decreased by 79%. You can also see that these trends are not unique to physical therapy. These same trends are matched by our rehab colleagues in occupational therapy and speech-language pathology. In summary, in 2019, there was one in-network physical therapist for every 41 Heritage Health members. Today, that ratio is one physical therapist for every 320 members. And I suspect after another rate freeze for fiscal year 24-25, despite rising practice expenses, we'll see an annual report that continues to demonstrate an even greater patient access issue for Heritage Health members seeking physical health services. So on behalf of our members, I respectfully ask you to consider these unintended consequences that are occurring with the way current provider rates are determined. And with that, I would be happy to answer any questions now or in the future, but thank you for this opportunity to address you.
Thank you. Are there any questions, committee? Senator Day.
Thank you, Chairman Hansen, and thank you for being here today. So you mentioned current ratio is at 1 to every 320 members. And then you said, and I suspect after another rate freeze for fiscal year 24-25, despite rising practice expenses, we'll see annual reports continue to demonstrate even greater patient access issue. I have asked a couple of other testifiers about the upcoming budget cuts and how that would impact their ability to provide services. What would that look like for you? Have you seen it?
Yes. And I guess on a little bit different topic, there's a section in there that talks about Medicaid expansion, but it's a little bit misleading. I think it's page 374 of the DHHS proposal.
Okay.
And it talks about, in a way of saving cost, removing services that are not federally mandated. All right. So that would include adult services for physical therapy, occupational therapy, speech, dental, vision, pharmacology, breast and cervical cancer screenings. All those things would be cut as the current draft states.
All of those things would be completely cut.
For adult
coverage.
services that are not mandated federally. That is a significant part of the savings.
Okay. Thank you.
Yes.
Senator Rigby.
Thank you, Chairman. We talked at one time about some reimbursement with Blue Cross Blue Shield and that issue. It's a little off of that, but every dollar impacts another dollar. You know, it's just source of cash flow.
Yeah.
Did you get that issue resolved
No.
with Blue Cross? No.
You're referring to multiple
Put Blue
procedure.
Cross on the spot if they're out here.
You're referring to multiple procedure payment reduction,
Yes.
which is a methodology that was actually once implemented in the Medicaid system, and Senator Walz led a bill LB 100 in 2021 that was passed that removed that really, I think, fraudulent methodology from the Medicaid system. And then Blue Cross implemented that in December of 23. And so our providers are seeing a 23% reimbursement reduction from Blue Cross, and that's likely affecting why they're having to make decisions on who they take care of. And for their lowest reimburser, they're being forced to make decisions that are challenging for them. But at Medicare, we've seen a 9% reduction over the last 4 years as well. So there's just challenges within our profession at this point.
Thank you. Thank you for being here. Thank you, Mr. Chairman.
Any other questions from the committee? Seeing none. Thank you for coming.
Thank you.
Appreciate it. All right, Kirsten Reed with Leading Age. Welcome.
Good morning. Is it still morning? It's still morning.
We're still in the morning. We're doing good.
Well, good morning, Chairman Hansen, members of the Health and Human Services Committee. My name is Kirsten Reed, spelled K-I-E-R-S-T-I-N-R-E-E-D. Thank you for allowing me to provide testimony today on LR 392. For the past 25 years or more, I have worked in a variety of health and human services fields, all generally funded through Medicaid. I've sat through plenty of rate increase hearings. I feel your pain. Today, I serve as the CEO of Leading Age Nebraska, a nonprofit association providing advocacy for providers of long-term care services. Our members provide home and community-based services, waiver services, and nursing home services, all funded through Medicaid. We appreciate the committee putting forward this resolution to examine the process and methodology, as well as rebasing for these Medicaid service rates. The emphasis on maintaining the quality of services by ensuring that the rates meet the needs of the providers and their workforce, and to ensure fair rates for all providers is echoed by our association in this process. I've provided the committee with an overview sheet as well as a longer form document that outlines what we feel are important factors for Medicaid rate methodology. So in my testimony today, I'm just going to provide a few highlights on that. First of all, rate methodology should be extended beyond direct care costs and historical data. Nationally recognized metrics such as Bureau of Labor Statistics should be used in addition to cost reporting information. Wages are a direct constrained expense based on what the provider is being paid and do not adequately reflect what direct care staff should be paid. We also believe that wage calculations for the cost of direct supervision should be included in direct staff. This is an essential component to make sure that effective direct care staff supervision is taking place. Direct care costs associated with providing services that are required under regulations need to be factored into the methodology. This could include technology, supplies, travel, physical spaces that are needed, and without those essential items, those services would not be able to be provided. The committee should consider the frequency at which rates are rebased, and a schedule is recommended for doing that on a rotating schedule. More importantly, the legislature needs to work towards implementing rates that are determined to be rebased as soon as they're rebased. We have a huge lag in that. We also believe that an inflation factor or adjustment for that cost should be done annually to keep up with the rising cost of care in between those rebasing periods. Members cannot wait for those rates to be rebased before they're able to hold up on those. I do have a few more items. I know the chair is not here.
Oh, go ahead.
You want me to continue? Thank you. A few more factors. There's been a lot of discussion about each service having its own methodology or kind of wrapping that all into one. These services are so distinctly unique that really each one does need to kind of have its own methodology. I'm sure there's some that could be grouped together, like those home and community-based services, those kinds of things. But each one has really unique regulatory requirements. There's also been discussion about rates being the same across the board. Right now, some rates are separated by urban and rural. Those factors are really outdated. I mean, we have trouble finding staff anywhere in the state of Nebraska. Those costs of supplies are generally the same everywhere. And there's certain rates and services that are negotiated, and we really do not feel that they should be negotiated. They should have a fee schedule. However, I do believe that there should be exceptions, or we should have an outlined process for how to get an exception. We don't want people waiting on services. There was a discussion about acuity earlier, and whenever possible, having things measured out by the level of acuity of the person that they're supporting would be best. And lastly, we believe that those quality components should really be done based on an additional factor to increase those services. It shouldn't be really in that base rate of those services. I'm happy to answer any questions you may have. Thank you.
Thank you. Are there any questions from the committee? Senator Reapy has none. So,
wow.
Thank you.
And so again, the common theme of rate, more of a universal rate methodology in your aspect would be good, bad, indifferent?
The term universal is problematic.
Yeah, I use that vaguely, I guess. I mean, it'd be more industry specific to some extent, but like
Yes.
getting a broad-based approach as opposed to what we're currently doing.
I think the way that we're currently doing things is when there's a problem, a group comes to the legislature and says, hey, we have a problem with this. And then they do a rate study and they determine that, yes, there's a problem. And then we get that issue resolved, maybe. We should just have a standardized process. I mean, that's going to stop the hordes of people coming in and saying, hey, we need a 5% increase in our rates or a 10% increase in our rates. If they know what that predictable schedule is for those reviews to be taking place, and that inflation factor or that annual cost is really being reviewed, at least on a biannual basis, you know, in between those full rebasing periods.
Okay. Seeing no other questions, thank you for coming.
Thank you.
And lastly, Sarah Bartruff from Mosaic. Hope I got that right.
Is this a master's thesis?
It is. Worked very hard on it.
Oh,
Good morning, Chairman Hansen and members of the Health and Human Services Committee. Thank you for the opportunity to share my testimony regarding LR 392. My name is Sarah Bartruff, SARABARTRUFF, and I'm the Director of Financial Planning and Analysis at Mosaic. Mosaic is a provider for adults with intellectual and developmental disabilities. We have a long 111-year history of supporting people in community settings that was started in Nebraska. Along with Nebraska, we also provide services in 11 other states. Given our rich history of offering services across many states for many years, we appreciate when states take the opportunity to reevaluate their current process and seek feedback on improvements and simplifications. Mosaic supports LR 392. Creating a rate rebasing system that is future thinking and allows for changes as the economy and environment around us transform is powerful. As a multi-state provider, Mosaic has seen success in other states where having a clear and concise rate methodology helps not only the state, but the providers and ultimately the people we support. Rhode Island is a great example. I have attached a copy of their rate methodology with my testimony. They very clearly outline in their residential rates specific direct care hours, wages, supervision, benefits, mileage, admin, program supports, and other professional services that are needed. This clarity helps providers know how to properly project, budget, and analyze their actual costs. Mosaic also offers up the following considerations for the study. 1, incorporating an inflation factor. Incorporating inflation into the rates allows providers to keep up with the rising costs and allows providers to be competitive against other industries, which are price setters while we are price takers. 2, focus on incentives for providers who are actively providing services that increase the quality of life for the people we support. Services that do this include shared living, community inclusion, and supported employment. These services integrate the people we support more into the community, stabilize staffing, and allow for lower overhead costs, which allow more of the current funding to go towards direct support professional wages as needed. Nebraska ranked the lowest of the 32 states in the NCI IDD 2022-2023 report in terms of individuals feeling included in the community. Those in shared living, though, did present an 8% more likely to feel that they were included than those living in a group home. And 3, have independent providers contract with agency providers as opposed to the state to provide more effective monitoring. 4, rates should be progressive, not solely based on previous fiscal year's financial data. The rate methodology should consider any rules and regulations coming down the road that providers will need funding to prepare for. To help ease the transition to this new model, the state should utilize the waiver-based cost reports providers of DD services in Nebraska have been submitting to DHHS for the last several years. These reports include provider revenue and expenses by service description, as well as salary details by position. Currently, these reports are primarily informational. However, in a newly designed system, if DHHS were to allocate resources to verify the accuracy of the data submitted, they could include this data into rate rebases, which would save time and duplicative work in the future. These reports also contain very valuable data about providers and could help identify issues or trends. One problem Nebraska currently has is that providers are not consistent when choosing how to utilize the funds they are currently given. In some of the most recent cost reporting data, some providers had margins as large as 70%, while some providers were reporting losses up to 24%. Utilizing the cost report data would create more transparency amongst providers and how they are conducting business. Providers need margins to be sustainable in the long run, but too large of a profit margin opens up concerns about integrity of the revenue, payment for staff and contractors, and overall quality. As a national provider, Mosaic would love to partner with the state of Nebraska in developing this process, as we have learned a lot about this rate setting over the years across many states. Thank you for listening, and I appreciate all you do to help better support and serve the people in the state of Nebraska with intellectual and developmental disabilities. I'm available for any questions. I'm sorry, I went over my time.
That's all right. Any questions from the committee? Senator Reed.
I didn't want to disappoint you. Thank you, Chairman. I've been around for a while, but this maybe exposes what I should know but don't. Within the Division of Finance, do we have a department as such that's dedicated to rate setting? I mean, everything that we've heard this morning, I mean, the complexities of it, each one is a little bit different. And, you know, it sounds like, I'm not trying to run up staffing costs, but it sounds like a focused kind of almost financial people in their kind of a setting that look at formulas, look at models, make recommendations.
There is that right now, and that would be wonderful. Every department, I believe, is left to create their own methodologies. A lot of times they work with outside contractors, but again, it's not as significant as people that actually would work within the state. And so you're getting a lot of people from the outside that are coming in.
Seems that would be one function along with maybe an HR function that we as a legislatures need. But thank you, sir.
I think it's almost kind of goes back when we talk about foster care, about the idea of having a committee that kind of reviews a lot of this. I know the finance division of DHHS and does a lot of, they look at a lot of the rates and how they're determined, I think, in rate studies. I think you brought up a good point about, and I don't know for sure how this applies to others, about not being consistent when choosing how to utilize the funds they're currently given.
So we had met with Director Tony Green a couple of months ago, and he had let us know that of the cost reports that people are submitting, some people are reporting margins of over 70%, and some have negative margins of 24%. So providers are clearly choosing to spend their funds in very different ways, even though we're all being paid the same rates. It's a bit concerning how some people can have so much in their pockets and some are losing so much providing services. So there's a lot of discrepancies that it would be interesting to take a look at and find out more. He said that right now that they just don't have the funds to have people go in and actually dig into these cost reports to find out what is happening with providers. And so I just found that fascinating.
No, you go ahead with your first, sorry.
Okay. And right now, you mentioned inflation. Is inflation currently factored in?
Not in our waiver rates, no.
Okay. And what are the sources of funding does Mosaic usually?
We're 99% Medicaid funded.
Okay.
We are a nonprofit, so we do fundraising to help cover those costs where Medicaid cannot, but we are still 99% Medicaid funded.
Okay. And I can't remember if you alluded to this in your testimony, but in your opinion, have rate studies been helpful for Mosaic?
They have been. I wouldn't say 100%, but it is enlightening to see how other providers are spending their funding, to have those discussions with providers, see if there's ways that we can make improvements on our side, as well as areas where we know we're doing a good job or we need to put more resources towards. So they're helpful. Yes, the last rate methodology that the state of Nebraska did, they did a nice job of outlining how they came up with the costs. It's just the data is so outdated at this point. And I don't know if that data was available to all providers. It was available to providers that helped in the initial rate rebasing committee.
Senator Walls, did you have a question?
No, it's all right.
Okay.
Thank you.
Thank you, John. I have a question. Do you have a pent-up demand for Mosaic that you obviously would, if you could, expand into, or you feel like you're meeting the demand at this time?
Oh, we'd always love to expand and to provide more services.
The demand is out there from the
Yes,
market.
there's community out there needs services, they need supports. A lot of times staffing is our issue. A lot of times finding the right, if we do a lot of shared living, so it's somewhat similar to foster care. Finding the right matches, having the time to put those matches together. There's a lot of competition out there for that particular service in the state of Nebraska, where you have a lot of providers paying very hefty percentages to attract people, but at the cost of what quality?
I have another, believe it or not, another question. I think you have a home, don't you, in Beatrice?
We do. We have an ICF facility in
I
Beatrice.
think we have, maybe off base here, tell me if I am, that I think we've limited or stopped admitting to the Beatrice State Home with the idea of trying to move over more towards a community-based. Because of, quite frankly, the cost at the Beatrice State Home is very, very high.
It's
for
very,
patients.
the ICF daily rates are much more expensive. They're much higher, about almost $200 a day more than our community-based rates.
I think
Yes.
the rates, the annual cost is about $285,000 a client, a patient.
Correct.
Senator Day.
So you mentioned those cost reports, talking about Director Green and mentioning,
Yeah.
some providers had margins as large as 70% and then others were reporting a loss of 24%. Are those cost reports available for us to look at?
We have been told they are public. So
They are
anyone can
public.
request them
Okay.
and go out and look and see what providers have
Okay.
reported.
Because I would wonder if some of that discrepancy could be attributed to rural versus urban providers and the higher costs versus lower costs and that kind of thing.
And probably amongst what services each provider is providing, there's an array of services that can be provided. So depending on what services you're providing, your costs are definitely going to be different.
Right.
So,
Okay, so those are publicly available.
those are publicly
Okay,
available.
we'll find them. Thank you.
Yes.
Any other questions from the committee? Seeing none, thank you very much.
Thank you so much.
All right, well, that concludes our invited testifier list. And just to make sure, like I mentioned in my opening, is there anybody in opposition? I just want to make sure I include, so I don't forget anybody. Okay, good. So everybody loves this idea. That's great. But there was 3 letters for the record. There was 1 in opposition and 2 in the neutral capacity. So I will come up to close. Okay. Well, I first want to thank all of the invited testifiers. I know they've been very open and honest and willing to discuss the idea of a different way for rate methodology that might be, like I said, not so much universal, isn't really so much the term, but more industry specific. And they work very well with Bryson and Benson in our office. And so I appreciate both of them taking the time and meeting with them throughout the whole summer. And I think what I was hoping to glean from this hearing was to at least see what the common themes are among everybody who came to testify. A lot of them, which you heard, was outdated rate studies, reviews, the inappropriate, inadequate provider rates in certain industries, some maybe not in others. And so the whole idea was to kind of garner information as best we can and their concerns about maybe what they would like to see done in a more broad-based universal rate study or methodology that we can incorporate somehow. This is a very complicated task, I think, because like Senator Repe said and others, that it is very industry specific. There's a lot of different rules and regulations for each one. And so you just can't say everybody gets a 2% raise no matter what. I think it does have to be a little more specific than that. So whether we can come up with something here this year or sometime in the future, I think a lot of this information will definitely help shape the future of provider rates and the methodology that we can use. I think a lot of it has to include some form of inflationary component, cost of living component, what surrounding states are doing. And I think then to be recognize our constituents and the taxpayers in Nebraska also understanding what our revenues are going to be now and in the future, and then how that might also affect provider rates. And so I'm hoping that maybe all those components can maybe be included in some kind of different rate methodology, because obviously from what we heard from everybody here, it seems like what we have been doing or what we're doing currently now is maybe a little bit more inadequate or not as efficient as maybe we can do for our constituents. So that's what I'm kind of hoping to do with some of this. So I'll take any questions.
I'd simply like to commend you for bringing this, I think it's something we all were aware of, but I think it brings the intensity of it. And so we turned a rock over, and I think that that's very good. I also wanted to comment, this last session in 24, I did have a bill in that increased some reimbursement for pharmacies filling Medicaid scripts, but we're still falling very short on that as well. We got what we could get, but it seems to me like we're falling short on every time we turn around here. But thank you again.
Yep.
I appreciate your personal attention to it.
All right. Thank you very much. And that will conclude our hearing for LR 392.